Hi guys, and welcome to another episode. In today's episode, I'm going to be giving my reaction and my review of Judy Cho's latest video, course from Nutrition with Judy, The Problem with Paul Saladino. The TLDR, because this is going to be a long video, because Judy's video is quite long, I'm going to be giving commentary on what she says and also some of what Paul Saladino says in her review video, of course, as well. The TLDR is I agree with a lot of what she's saying, but I also disagree with some of it, and I'm going to be giving my commentary throughout the video. I disagree with the conclusion, the intimation that she is essentially saying that Paul Saladino didn't have problems because of the carnivore diet and there are other issues going on. I disagree with the intimation that his problems were not fixed by adding carbohydrates back in. She's saying that because she's saying there's other issues still going on and that these may have caused Paul's problems and they're not being addressed. I agree with that. Looking at Paul's bloods, there are issues that he's either not aware of or he's not addressing. Paul's problems on the carnivore diet, I mean, he spoke about them very, very often in a lot of his videos. Unless he's lying to us, which I don't believe he is, his problems went away when he went on the carnivore, when he went off the carnivore diet and added back in carbohydrates. I don't think there's anything in Judy's video that disproves that. And I think she's trying to disprove that, but I don't think she's done a very good job. I don't think she's disproved that at all from the evidence that she has presented. What she has proven is that the animal-based diet didn't fix all of Paul's problems. That's very true. But inadvertently, she's also shown that the carnivore diet didn't fix Paul's problems either. Now, she hasn't actually commented on that because, well, I can only assume she's trying to push the carnivore diet. That's kind of her thing. So I think she's kind of almost in a way actually shot herself in the foot slightly here by saying that, well, the animal-based diet hasn't fixed Paul's problems, but also neither did the carnivore diet. The takeaway here is Paul has other problems that he's either not aware of, in which case I would question why, because they're pretty basic stuff. But also, if he is aware of it, why is he not talking about it? And is he being a bit disingenuous with his followers and the things that he's saying? That, I think, is really the takeaway from Judy's video. I don't think she can really argue properly that carbs didn't help Paul Saladino. Let's get into the video. You guys can make your own mind up to see if I'm on the right path or whether I'm just talking nonsense. Let's have a little look.
Dr. Paul Saladino has shared over the years why a carnivore diet did not work for him and why, in actuality, that a carnivore or ketogenic diet would not work or is ideal for many. In this video, I am going to share why I believe Paul Saladino is wrong and what I think are the root cause issues.
The question here is, wrong about what? The intimation I think that Judy's saying is that she thinks Paul Saladino is wrong to add back in carbohydrates and that lack of carbohydrates was not the problem. The reality, though, is for Paul, it made a big difference if you believe what he says. And I don't think we've got any reason to believe that he's actually lying about this. It would be unusual and odd for him to do that. The intimation is that carbs didn't fix his problems, but what you can see from the video is that on the carnivore diet, Paul also had those problems. And in fact, the problems that Judy mentions were worse when he was following a fairly strict carnivore diet.
One of the key things that I learned in my journey from carnivore strictly to animal-based, that adding carbohydrates in improved my hormones, as you'll see, my thyroid, my testosterone. It improved my muscle cramps. It improved my mental clarity. It improved cardiac issues like heart palpitations, which are related to electrolyte issues. It improved so many things. I think I have a fasting blood sugar from when I was on carnivore. They're usually high 90s or hundreds because there is some physiologic insulin resistance, which is different than pathologic insulin resistance that develops when we are on a ketogenic diet.
This is very true. You can get a physiological insulin resistance. A lot of what Paul said there is quite true. I mean, I've seen this repeatedly now. People on the carnivore diet having problems, which admittedly may not be everybody, of course, But I see a lot of people now with problems on the carnivore diet. Now, you can argue that there's a selection bias there. People are not going to come to me if they don't have problems. Well, actually, some do. Some do want to come and see me just to get some blood tests done, just have a chat about it, make sure they're on the right path, just discuss it, get a doctor's view and all that kind of stuff. But yes, most people I see on the carnivore diet, they are having problems with it. I probably see about half a dozen a week. So 5 or 6 patients a week, at least on average one a day. Heck, the other day I saw about 6 people in one day that were having problems on the carnivore diet. Almost universally, those problems do go away when they add some non-carnivore food back in. You will hear some discussion about adding more fat into the diet. This is always said. I have never seen anybody having problems on the carnivore diet getting better, but those problems going away if they add more fat into the diet. It just doesn't really fix anything. It's pretty hard, I think, on a whole, to not eat enough fat on the carnivore diet. People talk about 20-80 and so on. Look, even if you pretty much just eat like normal meat, you're going to get about 25-75. People are adding butter and eggs and all these other things as well. Okay, eggs are 50-50 protein fat roughly, but they're going to have more fat in anyway. It's pretty hard to not eat enough fat on the carnivore diet unless you're really grossly under eating, which Paul wasn't doing. He was eating 2,500-3,000 probably plus calories a day on the carnivore diet. I don't think anyone could really accuse him of under eating. Getting back a little bit though to physiological insulin resistance versus pathological insulin resistance. This isn't really touched upon in this video. So I do want to kind of make this point. People like Paul Saladino, Judy Cho, Ken Berry, Sean Baker, Anthony Chafee, Bart Kay, all these other people in this kind of carnivore keto space. Robert Sywes, low carb addiction doc and so on. Very, very learned people, people that know their stuff. Even people like Ben Bickman, who is considered, an expert on insulin resistance, still to a certain extent get this wrong. Insulin resistance is a made-up thing. It's a human construct, to quote, or paraphrase perhaps Professor Bart Kay. It's a human construct that is really, there's no test for it. There's no way you can say someone is genuinely 100% insulin resistant or insulin sensitive. There's no test for it. There are tests that can approximate it. There are tests that can estimate. And there's some good tests, there's some very bad tests. And we'll talk about a little bit about that in this video. The thing that they kind of get wrong is this overt, distinct separation of pathological insulin resistance and physiological insulin resistance. The issue there is that physiological can become pathological. And this is the problem we see with things like gestational diabetes. So diabetes, type 2 diabetes, essentially in pregnant women. What happens there, and this is a really good example, they get a physiological insulin resistance as part of that pregnancy. Now, early on, that doesn't really cause them many problems. But as the pregnancy progresses, the longer it goes for, the more issues they can start to get. And eventually, they get basically diabetes and they end up having to be treated with medications like insulin because of the dangers of the diabetes. Now, when that pregnancy ends, almost completely, that physiological insulin resistance goes away, the gestational diabetes goes away. But that was physiological, yet it still caused them and potentially their babies a lot of problems. And this is why we have to treat them with medications like insulin. Now, there's other ways, of course, but that's the mainstay of treatment for most people with gestational diabetes. But that's physiological insulin resistance. So why do we even care about it? Well, because it becomes pathological. And this is the problem. Long-standing physiological resistance can potentially become pathological. Pathological, meaning it's a disease process, is really not distinct from physiological. They are effectively very similar processes, if not the same process. It's just one is to a point where it doesn't really cause problems. The other, it actually is causing issues. The question is, when does it become pathological? And that's the question that a lot of people in the keto space either don't understand or are not answering, or they're maybe being a bit disingenuous with it. At what point does that physiological become pathological? And that, I think, is a big part of this problem. Let's get back to the video.
the reasons that I am not a fan of ketogenic diets. I don't think that they serve us well long-term as humans. I do think that all humans benefit from some carbohydrates, even if you're obese, even if you're diabetic, even if you're overweight,
I would actually agree with that for the most part, and that's why I do advocate for a little bit of carbohydrate. I think short term, very strict carnivore, zero carb can be very useful for a lot of people. But inevitably, I see people having some issues and they start to add in a little bit of carbohydrates here and there. I don't think we need many carbs though. I think we need maybe like 20 grams a day, still well into the keto space, just not zero.
100 grams of carbohydrates a day minimum. Well,
I would not necessarily agree with that, but let's give it some context. So Paul is saying he recommends at least a minimum of 100 grams a day for everybody, regardless. Now, number one, Paul, as far as I know, is not seeing any patients day to day, real life, face-to-face patients. So it's very easy to make recommendations when you're not the one that's actually having any responsibility. You're not the one that's going to get sued. You're not the one that's going to get complaints when things don't go right. Number two, actually 100 grams is not actually that high though. People rail on Paul because he was carnivore, he's now not, and he's no longer keto, and they think he's gone crazy on the carbs. Now, that may well be true. People say he's a carb addict. He may well be a carb addict. I doubt he probably is, because he probably would have struggled a bit more on carnivore. But 100 grams, if we look at the research for low carbohydrate diets, is really still very, very squarely in the low carbohydrate territory. Most of the research for low carbohydrate diets, a lot of it at least, they really look at anything up to about 25% of calories coming from carbohydrates. Now, most people, certainly most doctors, this comes up all the time on my low carb doctor group, horrified by the amount of carbs that they're telling people is kind of low carb as far as this research is concerned. But the takeaway from that, 25%, roughly approximately going to be around 200, maybe 150 to 250 grams of carbohydrates of sugar per day. They're still considering low carb. The takeaway from that, though, is that a lot of this research shows benefit for people still at those levels. So I don't think it's, again, really accurate to say, oh, well, 100 grams of carbs is horrendously high and it's going to cause loads of people issues. No, actually, it probably won't. And even people with really bad type 2 diabetes, they're still going to get better even at 100 grams of carbs because it's still very squarely in that low carb territory.
Or stress hormones, things like cortisol, catecholamines, including epinephrine and norepinephrine. 100 grams of carbohydrates will take some of the stress hormones out of the equation, which I think will benefit you long-term as a human.
If you're listening to this on podcast, I highly recommend watching this on video, as I share a lot of infographics and a lot of information that will also most likely help you. Get ready. This video is a few years coming, and I finally got to sit down and share with you all why Dr. Paul Saladino is wrong about the carnivore diet.
I don't think he is wrong about the carnivore diet. Just going to put that out there. For some people, it can work very well. For others, it just doesn't seem to work long term. Adding some carbs back in can help some people. I think the key thing really with all of this is just not to be dogmatic, not to be overzealous, not to necessarily just stick to one thing. If it's not really working, go and get different opinions, go and listen to other people like myself, Judy Cho, of course, Paul Saladino, Sean Baker, Ken Berry, Anthony Chafee, etc. Listen to other people and make your own mind up.
Hey guys, my name is Judy Cho and I'm board certified in holistic nutrition, and I have a private functional medicine practice where we focus on root cause healing, and we have worked with over 2,000 carnivore clients and patients get closer to root cause healing. And we often start with the Carnivore Cures all meat elimination diet. I know that Paul really believed,
and that's where carnivore diet is fantastic as an elimination diet. It is the elimination diet. There is nothing better out there as far as eliminating foods and trying to work out what's going on with you. But it's not a cure for everything, which is really what Judy actually evidences in this video.
the carnivore diet didn't work for him, and that is why he needed to add a lot more fruit, honey, raw milk, and I guess now he drinks fruit juice but I am here to tell you why his synthesis, his overall analysis is wrong. Now, I wanted to lay a few graph.
I don't think it is. I think he's just not talking about a couple of key issues. And I think Judy's actually slightly wrong on this bit.
To make sure that we are on the same page when I'm using certain terminologies, because if we don't understand the same words, then we're not going to understand the same things. In many of the videos that Paul has brought up, he has shared that a ketogenic diet is not ideal for long term. And he shares why it's not recommended for pretty much anyone.
Don't know about that. I mean, it's recommended for a lot of people, but not everybody. If you're pregnant, if you're a young child, for example, babies, it's not generally routinely recommended. There are some things like children, epilepsy, for example, it's very often very useful, can be useful for people with certain cancer diagnoses, for example. People like John Hopkins and Paleo Medicina in Hungary, you know, they're using the Paleolithic ketogenic diet, of course, to try and help with cancers and so forth. So there's a lot of promise in ketogenic diets. I would disagree if Paul's telling that it's not useful for people, but there is some evidence that long-term ketogenic diet could potentially be harmful for people. And we do see this on people with very strict keto diet. They do have some issues in the longer term if they are honest with themselves, and their blood tests don't always show a lot of promise. They can have issues.
Defines a ketogenic diet, he is just saying that it means that there is pretty much zero carbs in the diet. I just want to make sure that he is not saying it's that you are in ketosis, that you have high ketones. He is saying that if you remove most to all carbs, that you are following a ketogenic diet. And so in that definition, a carnivore diet, a strict carnivore diet is a ketogenic diet. But a carnivore diet is safe and effective, and it's ideal for people.
Okay, I mean, for some people, maybe, yes. Big caveat here. I mean, she's not giving necessarily direct health advice, neither am I, of course. But for some people, it's definitely not going to be recommended. So carnivore diet widely across the world is not going to be recommended for routine pregnancy, for children, for babies, for very elderly people, for example, people with certain health problems. It's not going to be routinely recommended. Now, does it mean that you can't do it? No, of course. You follow your own whatever you want to do, but it's not going to be routinely recommended. There's probably some people it's not going to be safe and not going to be effective. And I think that is an important distinction to make.
People that are suffering from metabolic syndrome and any types of inflammation, which is pretty much everybody these days, but the key is to eat sufficiently. Now,
Okay, you can't just fix everything with the carnivore diet. And like, I know this is Judy's thing with the Carnivore Cure book, but you can't just fix everything with the carnivore diet. And this inflammation is a buzzword. It's almost becoming a cliche in medicine because people are using it for everything. And there's a lot of things that carnivore can help with, but there's some things that carnivore can't help people with. You can't just cure everything with the carnivore diet, unfortunately. It'd be nice if that was the case. I'd be out of a job, and I have plenty of patients.
Think that everyone needs to eat carnivore or strict carnivore long term, but you can eat strict carnivore long term, for short term, for long term, for however long you want to eat. And no one should be fear-mongered eating this way if you're eating sufficiently and you are supporting yourself by making sure you are tracking your symptoms as well as getting blood work occasionally. Now,
I think that's very, very true. I've mentioned it plenty of times. I'm a big fan of getting blood work, monitoring your symptoms, and actually just changing things up. She's very right. Nobody should be fear-mongered, shamed, afraid to follow the diet that they want to follow. And ideally, they would find a doctor, healthcare practitioner that's willing to work with them on what they're trying to achieve and so on. But at the same time, we have to recognize some people are going to have issues. And to say that it's perfectly fine and if you're having issues, you're wrong. No, that is not true.
in this video, while I'm sharing a lot of why I disagree with Paul, whether it's blood work, whether it's studies, I am also going to share some tidbits for you so that it will help you on your wellness journey. You'll get to see how our practice uses functional testing and why working one-on-one clinically is super important. Now, I am going to be going through a lot of labs, and I just want to make clear that labs are not only indicative of what you are eating. It also is impacted by sleep, stress, environment, and lots of other things that are happening in your life.
Which is very, very true. The problem is the kind of intimation here is that she's saying that the carbs didn't help Paul. So she's saying that the labs are not a reflection of the diet alone. That's the thing she's put on the screen. And that's very, very true. And she's saying that, there's more to labs than just your diet. But then she's kind of really suggesting that Paul was wrong to add back in carbohydrates because his labs didn't get that much better. Well, if labs are not a reflection of diet and there's other things going on, why is it a problem then that Paul added carbs back in? It just doesn't quite make a lot of sense. She's drawing conclusions that just aren't really there, in my opinion.
Your food and your diet can absolutely impact markers, but it is not the only thing. So I just want to make that clear. Secondly, if there are markers that I don't necessarily disagree with Paul or that are not relevant to this conversation, I am not going to bring them up. Near the end of the conversation,
But I might, so bear with me.
I'll also share a little bit about fructose studies. I'm not going to dive into it deeply, but
I'm not going to cover those, but basically what she's going to say is you can use studies to just kind of show whatever you want to, which, to be fair, is quite true.
All to share that whatever study you want to find to prove your case, you can absolutely do that. Just because I know that Paul is super thorough, I just want to make sure that I am super thorough and making sure what the boundaries or the scope of this conversation is. I am not going to talk about anything organs related, vitamin A, PUFAs or polyunsaturated fatty acids, thyroid, repeat, pro-metabolic. As you can see here, I have done a lot of articles and some YouTube videos on it. I've done a very popular repeat review. Now, I did do one video where I analyzed what Paul was eating versus Dr. Sean Baker, and you can see my synthesis of why beef and liver doesn't work long-term, but I will not go through specifically why I thought his version of carnivore was not ideal, but ultimately, I don't think he was eating sufficient fat. So if you want to see it, it will all be in the show notes. I also am not.
I've never seen anybody having problems on the carnivore diet that's got better with eating more fat. It just, I would love it to be that simple. I really would. It just never works. It never works. Just adding more fat does not fix the problems on the carnivore diet. It just doesn't work.
Talk a lot about fructose. I have done numerous YouTube interviews and videos from experts, doctors, as well as going deep into articles, even talking about how much to eat on carnivore. So if you are eating a carnivore diet, oftentimes people will undereat, which will then impact their thyroid and hormone function. And they may undereat fat, which I think was part of the problem for the way that Paul was eating. Now,
it really isn't. I can't stress this enough. I've never seen anybody get better by just eating more fat. It just doesn't happen.
Years, many of you have asked me, especially when I was sharing about vitamin A toxicity and a little bit of copper as well. But
vitamin A toxicity is so overblown. Again, it doesn't happen. It really doesn't. You'd have to be eating so much liver to get vitamin A toxicity. It's really not something that most people are going to have to worry about at all.
Eating too many organ meats, or especially beef liver, you asked me to talk with Dr. Paul Saladino and do a debate. Well, it obviously never happened, but that reason was not because of me. So as you can see here, in June of 2023, I emailed.
Maybe Paul just doesn't want to debate with Judy. Who knows?
Paul, and I think there was an email prior to this where I asked him to come on my podcast and that we can talk all things carnivore, fruit, etc. I've also messaged with him, but to no avail. Okay, so I know some of you are like, well, maybe Paul.
I mean, so have I, and he never got back to me. Does that mean that he's wrong? No, just means he maybe didn't get my messages or doesn't know who I am. I'm too small for him to bother with, any of these issues. And Judy, it might be the same. It doesn't mean he doesn't want to debate with her. Just maybe he's not even getting wind of it.
Doesn't even get your messages. Maybe he doesn't even know you. Well, let me share something. So I am the graphic designer of the Carnivore Code book. You can see that this was his first original. I did the graphics for that book. Then we signed a contract for his book that was bought out by a separate publisher. And you can see here in his book, it says illustrations by Judy Cho. My story is in there. And then Paul had a note about me as well. In the carnivore.
Okay, but that doesn't really mean anything. And she's saying this to make it out, to intimate that Paul doesn't want to debate with her. The intimation there being, the further intimation being that he thinks, that she's right and doesn't want to kind of admit it and so on. I think this is disingenuous and fluff and just
graphics. You could see all of these infographics. I worked with Paul to make this exactly how he wanted it to look. And this is his second version of the carnivore code where he changed some of the graphics. As an example, you could see here, he started adding the least toxic plants. Paul and I do have a personal relationship and we have worked together. And frankly, it would have saved us so much time if I just got on a podcast and had a friendly conversation with Paul. But since it didn't happen, I just wanted to clear the name of the carnivore diet. All right, so let's.
Okay, I mean, that's got nothing to do with the carnivore diet at all. So it just, Paul doesn't want to debate with her. That's it. That's the reality.
Into the crux of my argument. I want to talk about what standard care medical ranges are. We all get our blood work and we see the normal ranges. If it is out of range, you'll see a H or an L or a high or a low next to lab marker.
And reference ranges are garbage. No doctor should really ever be relying on them. They're useful for a very quick scan and so on, but nobody should ever be relying on them, though a lot of doctors do completely rely on reference ranges, which is a huge bugbear of mine because they miss so much pathology.
But where do those ranges come from? Well, this is from Merck Manual, and it says the standard care ranges are statistical averages of otherwise healthy in the context of an analyte being measured. It includes people with subclinical health issues. So if somebody is pre-diabetic.
Yeah, average population, they're based on average population. Here in Australia, it's probably the same. Elsewhere, they judge them based on the first 2,000 or so people that go for that blood test. They're based on average population. Average population is sick. It was over 93% of Americans, adults, have one or more markers of metabolic syndrome, metabolic health dysfunction. That's the average population that they're basing these reference ranges off. Otherwise, things like zinc, for example, I mean, everybody's low in zinc, but the reference ranges, they're based on people who are probably low in zinc, more likely at least to be, because their doctor's sending them for that specific test. It's not a routine test that most doctors will check. I do because I use it for hormones and so on, but a lot of doctors won't check that routinely. So it means that people are more likely to have a zinc deficiency if they're going for that test. But they're the ones being used for the reference ranges. It makes no sense whatsoever.
And checking their glucose, they would be part of that healthy population. But it says, while reference ranges do not usually allow 100% distinction between health.
Yeah, I don't know about diabetes being included in that. Even pre-diabetes, there's pretty well established standardized glucose levels across the board to diagnose type 2 diabetes and pre-diabetes. So I'm not sure I necessarily agree with that. The pre-diabetes, the insulin resistant and so on, yes, they are going to be included in this.
And disease, they generally represent 95% of the otherwise healthy population. Again, this healthy population includes subclinical health issues. And Paul brought this up himself.
But I think that the important takeaway from the whole discussion is that labs might look a little different when we're eating a lot of meat, a lot of saturated fat from animals. And the context is critically important. I say that all the time, but what I mean by that is that if you are insulin sensitive, I think that a lot of things change, and many portions of blood work get interpreted by well-meaning, intelligent physicians as if they are in a population of people who is massively insulin resistant. So
that is quite true, but there's a couple of problems with that. Number one, insulin sensitivity, insulin resistance, these things are, again, a made up construct, as we've already kind of mentioned. And the second part is that you can't really just do a test that says, well, somebody's insulin sensitive or somebody's insulin resistant. You can get a good idea, an estimate, but you can't really accurately just say one way or another categorically. someone's insulin resistant or insulin sensitive. The other part of this, and I see this all the time, Paul Saladino does it, Sean Baker, Ken Berry, Anthony Chafee, all these people, they're not consulting patients face to face. At least most of them are not consulting patients. They are not the ones who are interpreting these blood tests. It's doctors on the ground who are seeing these patients, who are interpreting the blood tests and then getting criticized by these online influencers. The problem is these influencers are not bearing any responsibility. They're not the ones that are going to get sued. They're not the ones that are going to get complaints when things go wrong. Their doctor, the one that's seeing them face to face, is. And they are mostly just trying to do the best they can. So I think it is unfair to criticize doctors for just mostly trying to do the best they can when they're the ones carrying the can. They're the ones with the responsibility. They're the ones that are going to get the complaints. They're the ones that are going to get sued if things go wrong, not people like Paul Saladino.
For the run-of-the-mill physician seeing patients, for a physician, for a doctor seeing patients that just walking off the street, if they had some of the blood markers, specifically the LDL that I have, they might be concerned about their cardiovascular risk if that person is insulin resistant.
So if we know that standard care is statistical averages of otherwise healthy, which includes subclinical health issues, let's look at averages of chronic illness in the US. 74% of Americans are overweight, 42% are obese.
I haven't fact checked this, but it's probably quite true. It's ridiculous.
60% have at least one chronic illness, 40% have two or more. Nearly half the US population has blood sugar regulation issues. Now, I just wanted to throw this in there as a tip, but 27.5% of US adults have high LDL, yet only 3% of the US adults have a heart attack. So maybe LDL is not the best marker to be tracking.
That is very, very true. However, again, disingenuous to say that LDL is nothing to worry about, that a lot of these influencers are saying, or at the very least intimating and suggesting that who cares about LDL. The other thing that's very commonly said by certain influencers is, that the majority of people who have heart attacks have a low LDL, and that may well be true. But a lot of those people are having secondary prevention on a statin because they've already had a heart attack. Now, you might say, well, statins don't do anything. And look, that may be true. They don't do a huge amount for most people who are prescribed them, but they've already had a heart attack. So they're already very, very high risk. Their low cholesterol is not going to save them, so to speak, from subsequent cardiac events. So again, it's disingenuous to say that, well, most people who have heart attacks have a low cholesterol, therefore we shouldn't really be worrying about cholesterol. As always, there's nuance to that conversation.
To also note is that only 21% of Americans get annual blood work. This may be limited to the access of healthcare, maybe insurance, health issues. If 60% of Americans have chronic illness and then they're the ones that are getting blood work, could the average statistical range of blood work be skewed for a little bit more chronic illness? In functional medicine, we use functional medicine lab ranges. These ranges are from...
So I'm not sure if Judy uses a specific functional lab for these that give her those ranges, or whether she's made them herself. But yeah, I would agree. Very often the normal standard reference ranges are mostly useless. And the truth usually lies somewhere in the middle, as always. And it is a good idea to kind of slightly compress those ranges.
Research, clinical experience, and also consensus within the community. So if normally in the standard care range, up to the pink section is considered within range, the functional labs, we would end the range right here and right here. So the functional lab ranges are much tighter than the standard care ranges.
Very, very true.
Standard care, while they look at statistical averages, they will diagnose diseases and monitor progression, possibly getting you on drugs or having to use surgery where cells, tissues, and organs may be damaged. But functional ranges right here, so a tighter range of markers will help you stay in optimal health and allow you to be more proactive. Now, here's
I think what she's trying to say there, but maybe badly, is if you wait until you're outside of the conventional ranges, then you're going to have a problem because by definition, then you've pretty much got the disease. And this is very true. Most doctors, on the whole, conventional doctors are very bad at actually preventing disease because, again, they're not really aware of that it's creeping towards diabetes. And actually, they really then just react when you actually have type 2 diabetes as an example. And they should be really preacting, or being proactive and actually addressing it before it becomes a problem. What she's suggesting is if they use more functional ranges when it's essentially outside of those functional ranges, but not yet outside of the conventional ranges, that's the time to act, which I 100% agree with.
Example with triglycerides. The conventional range for triglycerides is 150 milligrams per deciliter. Now, we know in the carnivore community that ideally you want to be in the 100. So in
You probably don't want 0.
the functional medicine range, you want to be between 50 to 100. Now, pro tip for some of the carnivores that are under eating fat and under eating in general, you actually want to be kind of between 60 and 100. And that's when I know a carnivore is eating sufficiently. I see way too many people that their markers are 45, 50, and it's oftentimes they are one under eating or
I have never seen a carnivore patient who has that low of a triglyceride level. Now I'm using Australian figures, not American. I've never seen a carnivore patient having that low a triglyceride level. Again, maybe that's why I've not seen people who are getting better with eating more fat. Maybe because they're all eating enough fat already, but they're still having problems with the carnivore diet.
they are under eating fat. So now I hope you guys understand what a functional medicine range is versus what the conventional blood work ranges is. When you wait until you are out of range for the conventional blood work ranges, you are risking disease that may be harder to heal. In our functional medicine practice, you could see this is how we look at it. You can see these optimal ranges, which we consider the functional medicine ranges, and then there's the standard ranges. So anything that's in yellow is considered out of optimal range, and anything in red is considered outside of the.
She could speed this up a little bit. This is going quite slow. I'm aware I'm adding more commentary, I know, but she's really laboring the point here.
Standard care range. I'm not going to go over this, but if you want to learn a little bit more between the conventional and functional labs and testing, you can pause this right here and just take a read. And so you know the nuance and differences.
But mostly I will discuss my recent blood work, which I just got a couple of weeks ago when I was in the United States. So late June 2022. The previous set of blood work was from late 2020, I believe. So it was a little less than 2 years. So it was too long, but I was doing a lot of traveling. So I've been doing different things with my diet, but for that entire time between the most recent set of blood work and this set of blood work, I've been animal-based. So the context for this blood work discussion is what I'm doing now with my diet. I eat meat about 2 pounds a day. I have a few ounces of different organs, heart, liver, that type of thing, testicle, bone marrow. I have fruit. So this is a new addition relative to my previous blood work discussions when I was strictly carnivore. So I have probably 200 plus grams of carbohydrates per day now from fruit and honey.
Which is quite a lot, but still potentially considered low carbohydrate. The context for Paul, as he said, context is king. You know, he's eating around 3,500 calories a day, roughly. 200 grams of carbs is still going to be below that 25%, cutoff. 3,500, I mean, let's just call it 3,600 for easier maths. 25% of that is going to be 900. 900 calories, divide that by four calories per gram of carbohydrate. That's going to be about 225 grams of carbohydrate. So it's still under that 25%, which is what a lot of the research actually uses for low carbohydrate. Let's give it the context.
So I'll discuss how that affects my blood sugars, how that affects my insulin sensitivity. So I have organs, I have meat, I have fruit, I have honey, and I have raw dairy, which I've been doing for probably about the last 6 to 7 months. I have raw butter. Occasionally I have raw cheese. I have raw milk from goats and cows, which I ferment into kefir. So that is the baseline I don't eat bread. I don't eat vegetables. I don't eat grains. I don't eat beans. I don't eat starches. And those are the things that I leave out of my diet. Hemoglobin A1C, 5.2.
Yeah, I would agree with all that. Bread, starches, most vegetables, pretty bad. Things like spinach, kale, etc., pretty bad. My diet mainly is low carbohydrate, low oxalate, mainly ketogenic, very high meat content, very high fat content, about 20, 30 grams of carbs maybe a day, a little bit more on the weekend.
Fasting blood sugar, 79. These are all very, very good in my opinion. I don't think anyone would debate that I'm extremely insulin sensitive, that my fasting blood.
Likely he is, but again, there's no real one singular test for this. I'm not sure about extremely insulin sensitive, given his HbA1c is 5.2. I've certainly seen a lot lower. If you were talking about maybe like 4.5, something like that, I would say definitely yes. Very, quite insulin sensitive. Yes, most likely. Extremely, maybe not.
Is exemplary. And my hemoglobin A1C of 5.2 reflects an average blood sugar of 103 milligrams per deciliter over the last 90 days. This is important. So what do I want to talk about here? I want to note that with a massive amount, quote unquote, of fruit and honey in my diet, I remain extremely insulin sensitive. I don't think anyone would argue that.
It's massive as opposed to a carnivore diet, certainly.
There are people on the keto side who would say honey is bad for you. And hopefully I'll be able to have conversations with them in the near future and talk it out in an interesting way. But I disagree. I think there's lots of good.
Judy's face when he says that.
Honey is great for humans. I've shown it many times on the podcast previously.
I did a video on why blood sugar goes up on a carnivore diet, and I talked about how to track symptoms and also check blood sugar levels. And I also mentioned tracking certain blood markers, including getting your NMR panel and looking at your LPIR score, which is a sign of insulin resistance.
Which is very useful to do, yes.
Also get your C-peptide as well as your insulin, your fasting insulin, even though fasting insulin shifts a lot because it's a hormone. And
fasting insulin does shift a lot, absolutely true.
Also shared a few studies where dolphins show insulin resistance when they are eating a carnivore diet, but why
are we talking about dolphins?
Eat a diet where they add carbs, their blood sugar normalizes. But is this a new normal because this is a different way of eating, and maybe our blood sugar is not being absorbed as quickly from the blood compared to somebody that's eating carbs? So
okay, but the problem there is, no, it's not a new normal. If your blood sugar is raised in your bloodstream for prolonged periods of time, that increases glycosylation. Glycosylation is, as far as I'm aware, universally pretty much a bad thing. We want as minimal glycosylation as possible. Now, we obviously need a baseline level of glucose in our blood. We don't want to get hypos, but it's not a good thing, as far as I'm aware, that it's hanging around higher for longer. And this is something that I think a lot of the carnivore community, especially, just, I don't know, they just say like, oh, it's fine because carnivore, because my glucose is higher because carnivore, and that's fine. But no, high glucose is bad. We don't want it being elevated for prolonged periods of time. It doesn't make any sense to me that this would be a good thing.
Of course, Paul's blood sugar is going to go down because the body is using it. If our blood
which is a good thing. Not quite why she's suggesting it's a bad thing that his blood sugar is going down.
Is naturally higher because we have less in store, that makes a reasonable response so that there's quicker access to the glucose when you don't have a lot stored in your liver.
Again, that may be true, but if you're physiologically insulin resistant, you're going to be fat adapted, most likely. Your body's going to be utilizing fat most of the time. Why do you need quick access to glucose? Well, you don't. Your brain needs a little bit of glucose. That's it. Everything else can use ketones. Why do we want rapid access to glucose? That doesn't make any sense.
Blood sugar goes up and you are feeling unwell, then that is a different story.
One way.
Yes, that is very true. But the vast majority of people with insulin resistance, pre-diabetes, even diabetes, don't know they've got it. They don't have symptoms a lot of the time. So to simply just say, well, as long as your blood sugar's high, but you're not getting symptoms, it's okay. No, that is not okay.
Tell that you're insulin sensitive. One proxy is a high HDL and low triglycerides. I showed Framingham study data. What you saw was that people with the highest levels of HDL had essentially no relationship between LDL cholesterol and cardiovascular risk. HDL in that situation was a proxy for insulin sensitivity, or low HDL being a proxy for insulin resistance.
So I agree that many times if your HDL is higher and your triglycerides are low, that can be a sign of insulin sensitivity, but it is not always the case. And
True. The question again here is, what is insulin sensitivity? I've seen people with, and I talk about getting LDL subfractions checked, oxidized LDL. I've seen carnivore patients specifically. I've never seen it on keto, maybe once actually. Otherwise, I've never seen it on keto, never seen it on low carb. Heck, I've never even seen it with a standard, Western diet, though generally my patients are carnivores and so on. I've seen it with a very low HDL, sorry, high HDL, low triglyceride. And this is seen as the quote unquote poor man's insulin test, or poor man's lipid subfractions, as far as people like Ben Bickman are concerned. That's what they say. The problem is it's a very poor man's LDL subfraction, because it can be wrong, grossly wrong. And there's other things going on in the body. Most of my strict carnivore patients, in fact, actually every single one of them, have a bad oxidized LDL level, and getting worse on the ones that I've done subsequent testing for, who haven't added back in the carbs. The ones that have, added back in some carbs, their lipid subfractions, LDL subfractions, have got better, less oxidized LDL, less small dense LDL, bigger mean particle size. Those large, buoyant, fluffy LDL particles, that's what we're looking for. Now, their fasting insulin remains low. Their HbA1c is actually creeping up. Maybe they are insulin resistant. That's why, again, there's more to the story here. But simply just going off an HDL and triglyceride may land you in some trouble.
interestingly, Paul's 2024 blood work, that HDL to triglycerides gets impacted, but he doesn't bring it up in the 2024 blood work. This is a sample client of ours, and as you can see, her HDL is 82 and her triglycerides are 61. This, by any definition, would be considered super insulin sensitive and super healthy. Now, if you look down here, her insulin is 10.1 and her C-peptide is 3.1. Something is going on that her insulin is going up. And this person eats carnivore, but you can see here, while her lipid panel looks pretty good in a meat-based, healthy, insulin-sensitive way, she in fact is not insulin sensitive and something is going on. While the Framingham studies...
Okay, so she's carnivore, but she's getting more unhealthy, is effectively what Judy's saying there. She's becoming insulin resistant, even though she's on a carnivore diet. So what's going on? Now, again, it could be physiological, and yes, that may well be true, but I've kind of touched on that already. I don't think that's really just a great thing to just say, yeah, you're physiologically insulin resistant, no problem, carry on.
show that it is not always the case. High HDL and low triglycerides does not always equal insulin sensitivity. In fact, this blood work is pretty common within our carnivore patients. Now, they are
Hang on. This blood work is pretty common in their carnivore patients, and she's saying this person is not actually healthy. Is carnivore good or not? I mean, I don't know.
from some type of other chronic illness, but I'm just letting you know that your insulin can be high even if your HDL and triglycerides look beautiful. And another pro tip, if your HDL is above 85, there can be a sign of inflammation. It is not good just to have super, super, super high HDL.
That is very true. Studies like the ARIC study have shown that high HDL is associated, well, very high HDL is associated with an increased risk of cardiovascular disease as well.
We don't care as much about the blood sugar. We care about how the blood sugar is reflecting insulin. And as I showed you just earlier, that blood sugar can be normalized, your LDL can be normalized, but your insulin can be out of range.
No, we care about blood sugar more than we care about fasting insulin levels. Yeah, we care about blood sugar a lot.
So for Paul, because he's eating sugar, his insulin is obviously working right now to reduce it from the bloodstream and get it stored in the liver.
Which is generally a good thing. It's also going to be stored in the muscle as well, glycogen, muscle, and liver.
If your insulin is low and you test all the other markers on a carnivore diet and your blood sugar is in the 90s, I don't think it's an issue.
Based on what? Just because you're carnivore? I disagree. I think if you've got a high blood sugar, I think there's a problem going on. And sustained high blood sugar is a problem, whether it's physiological or pathological. That will eventually become pathological.
That is a separate topic.
True.
What I do want to share is Paul's DHEA.
And this is where we get to the crux of what Judy is talking about. I'm aware this video is almost 45 something minutes long already with my commentary, but DHEA is a problem with Paul Saladino.
Maybe Paul's testosterone went up, but his DHEA is actually very low.
What we don't know from this video is what happened to the DHEAs, so dehydroepiandrosterone sulfate, which is an androgen, commonly used for as a way for measure or to kind of express or estimate is the better word perhaps, stress and some sort of stress response. If your DHEAS is low, you likely have some sort of chronic stress response. If your cortisol is low as well, you may well have some sort of adrenal insufficiency or adrenal fatigue syndrome, which again, in conventional doctors, they poo-poo that, they don't understand that, they don't acknowledge that, but I do see some people with this. If your cortisol is high and your DHEA is low, you probably don't have adrenal fatigue because they are producing cortisol, but you have a chronic stress state otherwise. Paul's DHEAs is low, are low. We don't know why. But the thing is, this was, 6 months of animal-based or so 18 months of animal-based. We don't know what they were on carnivore specifically, which I would really like to know. Judy is making the intimation here that animal-based did not fix his DHEAs, therefore animal-based is wrong and there's something else going on. But it's also extremely unlikely that carnivore animal-based has destroyed his DHEAs. Carbohydrates generally increase, or the carbohydrates that Paul's eating generally would increase DHEAS, or DHEAs. So I don't think, again, you can kind of really conclude that animal-based is bad based on Paul Saladino's DHEAs. He likely had this problem, or worse, when he was actually strict carnivore.
Conventional ranges are in orange. So if any of the markers are out of range, they will be in orange, and it will be because they're out of the conventional range levels. The optimal ranges will be in yellow when they are out of range. DHEA in conventional ranges is between 65 and 510. That's a pretty large range, by the way. And optimal ranges is 350 to 490. Again, that's the functional medicine ranges. Paul.
That's for male. Females will have different DHEA optimal ranges. Women generally a lot lower than male. Interestingly, DHEA also tends to lower as we age, though I'm also very often thinking nowadays, is that normal or is it just what happens? Again, coming back to reference ranges. Paul's not particularly old, so his DHEAs should still be very high. And I've got some 70, 80-year-olds with very high DHEAs. So again, I don't think it's necessarily a thing that just happens.
In 2022, where he is eating carbs, is at 79. Now,
which is very low.
DHEA. So DHEA is a precursor hormone to sex hormones, and it's typically produced by the adrenal glands. Low levels suggest adrenal insufficiency or chronic stress. Often,
which is what I've said, but the cortisol would be very useful here. So his cortisol is actually okay on the whole, looking at these blood results, which suggests he more has a chronic stress response or some sort of chronic stress as opposed to an adrenal insufficiency or an adrenal fatigue syndrome.
when our DHEA is low, it's a sign of fatigue or being under stress. DHEA is produced primarily in the adrenals and is the most abundant circulating steroid in the human body and influences more than 150 known anabolic functions throughout the body and brain. It is the precursor for sex hormones, including testosterone, progesterone, and estrogen. And again, it's not flagged here because it's considered conventional ranges. He's at 79. Why? Especially when you are saying that after consuming 200 grams of carbohydrates is improving your hormones, allowing you to feel less stress in the body, but then explain the DHEA.
Again, I think that's two separate points, and Judy's conflating these, I think, there. And again, she's trying to intimate that carbohydrates are not fixing any of his problems and that they are potentially, in fact, the problem. No, that's not the case here. These are two separate issues entirely. I do agree, though, that Paul should be picking up that his DHEAS is really low and that there's clearly some problems going on here, which he doesn't seem to be aware of. I would agree with that.
When I see a DHEA this low, I always wonder what stress is going on in the body. And I usually look at the immune function, and we'll talk about that in a second.
And that may be true. Almost entirely, my patients where I see a low DHEAS, it's on the carnivore diet. And adding in carbohydrates almost always fixes that. And it improves things for the most part.
If 200 grams of carbohydrates is allowing Paul to feel less electrolyte imbalances or mineral imbalances and allowing him to feel less heart palpitations, that does not mean that the root cause of why those things were going on is now gone. When you consume carbohydrates, you retain more water. It is why people, when they eat carbs, they feel bloated.
Yes, that is true. People often feel bloated with carbs. They will retain water on carbs. That will help. Carbs also will stimulate things like aldosterone production, which can help to retain things like potassium and so on as well. I think I see what she's trying to say here, but I would disagree. I think if you change one variable and it fixes the problem, it probably was the problem in the first place. I don't think adding carbs is a mask or like a pseudo fix for this. I think if he added carbs, the problems went away. I think you can probably just say that the lack of carbs was the problem, actually. Yeah, I think she's, again, slightly disingenuous with this or just conflating things a little bit.
Times that bloat is because for every glucose molecule, you are retaining water molecules. So when Paul eats carbs and feels less electrolyte imbalances and heart palpitations, I believe that because he's storing more water.
Yeah, okay. But again, if carbs fixes the problem, why is a lack of carbs not the problem?
Is the true root cause imbalance of those electrolytes healed from eating 200 grams of carbs? I don't think so, based on his blood work from 2024.
Okay, but what is then the root cause of his problems? This is what Judy's failing to mention, unfortunately. She's saying that he's not fixed it, even though his symptoms have gone away, but she's not offering an alternative explanation as to the problems he has with electrolytes specifically.
We'll get into that more in a second. So we now know, though, that his DHA from 2022, when he started adding carbs and started feeling better, was low, and it is often indicative of a person that is under chronic stress and is possibly having adrenal insufficiency. It is from adrenals that
his cortisol's fine, so it's very unlikely that he has adrenal insufficiency. Plus, he'd also probably just be feeling totally shit if he did as well.
feel the cortisol imbalances that he is talking about, that he is faulting for a carnivore or ketogenic diet.
This is the most important piece of this blood work, is to show you guys the context. I'm insulin sensitive and I eat a load of fruit and a lot of honey per day. How much? Today I think I've eaten an entire papaya. I've eaten close to an entire
Does anybody like papaya? It's disgusting.
pineapple. And I've probably had
I guess Paul likes papaya.
3 to 4 tablespoons of honey already today, and I haven't even eaten dinner. Now, dinner will probably be another 50 to 75 grams of carbohydrates, but that's a lot of carbohydrates that I've already ingested.
That's a lot of honey. And the problem with honey is a lot of the time you don't know if you're getting real honey or just actually high fructose corn syrup. It's a problem.
Causes pathological insulin resistance, seed oils, and processed sugars. I think that can lead to some degree of insulin-induced insulin resistance, but also metabolic insulin resistance, metabolic dysfunction. And I think that you can eat a lot of raw honey and a lot of fruit and not develop insulin-induced insulin resistance.
Now, Paul brings up that most pathological insulin resistance is from processed sugars as well as seed oils. I will tell you that from the ketogenic space, of anyone that does not eat carbohydrates or sugars, that I have seen markers consistently where their insulin and C-peptide will be low, even if they eat a little bit of seed oils. Now, I am not a proponent of seed oils, but I am saying I will see people eat ranch from the grocery store or go to restaurants and eat meats cooked in seed oils, and I will see that their insulin is still in a low range as long as they reduce the sugars.
Okay, but that is like literally just the tiniest smidge of seed oils. Now, I say this to my patients as well. Like, you go and have a spoon of mayo, aioli, ranch dressing, like she's saying, you go out and you have a steak cooked in some sunflower oil or something. Realistically, it's going to make absolutely zero difference to you. 100%, I would agree with that. But again, she's kind of trying to say that, well, Paul's wrong, that seed oils cause insulin resistance because of some people who eat a little bit of ranch dressing on the side for some of their meals. Like, no, like that's two totally different things.
Paul talks about how processed sugar can also cause insulin resistance. So let's talk honey. I will put all the sources in the show notes. Honey is the third most counterfeited food in the US. Tests reveal that 50 to 70% of US honey is fake or adulterated.
It's probably the same all around the world, to be honest.
Including corn syrup, high fructose corn syrup equals processed sugar. 76% of grocery stores contained no.
And they never put the ingredients on the back. It just says honey.
Which means fake honey, which means high fructose corn syrup. And also, Manuka honey is known to be so beneficial for your gut. And if it's real and raw, it can be. But if it's not, it can exacerbate the issues you're having in your gut. And 6 out of 7 Manuka honeys are fake. So if we talk about the risk of insulin resistance, I think you have a higher chance of having insulin resistance just by buying honey that is most likely fake.
Yes, look, that's probably true as compared to eating a little bit of ranch dressing or, a steak that's been cooked in seed oils, for example, as a one-off going out to a restaurant. But that's not what Paul's saying. Paul's saying that seed oils are a big problem for people that are consuming them in high quantities, not the very occasional little bit of ranch dressing on the side. I would agree, though, that a lot of honey is processed, it is fake, and it isn't good for you. The question is, can you get real, pure, organic, etc. honey? Paul Saladino, I'm sure, probably has quite a lot of money. He can probably afford to make sure that he is buying the proper stuff. Us mere mortals, we maybe don't have that kind of money. So your chances are you probably are going to get fake honey unless you are making it yourself, the source extremely well, for example. And you should try and actually get some local raw honey. It tastes very different to even raw honey from the supermarket, quote unquote raw honey from even organic, health food store. It tastes very different. So it really begs the question, are you actually buying real raw honey, even if it's from a health food shop? You probably aren't.
Homocysteine. I want to talk about this one for one moment. Again, this may get a little complex here. Homocysteine is something I've talked about in the past. I've done entire podcasts on homocysteine and on MTHFR. I am Italian. I am homozygous for the 677C to T polymorphism in the MTHFR gene, which is part of this methionine or folate cycle. You can see here dietary folate, not folic acid, that is not occurring in nature. It is tetrahydrofolate or methylfolate or adenosyl.
Okay, well, it's not methylfolate. As far as I'm aware, and I've researched this extensively, you cannot get methylfolate in your diet, which is the problem with an MTHFR gene mutation. That's the polymorphism that Paul is talking about. He has the C677T polymorphism. We'll talk a little bit about this a little bit later on, but C677T, theoretically, you can eat high levels of vitamin B2, that's riboflavin, and effectively kind of bypass the MTHFR pathway. MTHFR stands for methyl tetrahydrofolate reductase, and it codes for the protein that basically turns folate into methylfolate, or methyl tetrahydrofolate, I suppose, to be more accurate. If you can't properly methylate your folate, you can't properly convert your homocysteine into cysteine, and I can't remember off the top of my head what else it goes down to. Taurine and some other things on there, it looks like. So you can't basically get rid of your homocysteine. Homocysteine will build up more than if you don't have this polymorphism. Simply just having more folate in your diet, or, taking folate tablets, although he's suggesting you shouldn't do that, simply just giving yourself more folate isn't necessarily going to fix anything if you're not properly converting. Homozygous, which is what Paul has, he has both copies of his DNA, so double-stranded DNA. Both of his copies are affected with this C677T polymorphism.
Come in through the diet, and those of us, Italians, Hispanics, tend to have this polymorphism.
It's very, very common in everyone. Probably about 50% of the population has this.
THFR enzyme doesn't work really well, or it works more slowly, which means we either need to get more folate into our bodies, or we need to find,
which doesn't usually make any difference.
Source
a little, but not a lot.
Methylfolate, or we need to get more riboflavin. So this is a really important thing.
So this is what I was saying. So C677T, the problem there is you need about 10 kilograms of lamb's heart equivalent per day to actually bypass effectively the MTHFR. Not even Paul is eating 10 kilograms of lamb's heart every day.
At the time of this blood work, I was traveling. I wasn't getting as much liver as I usually do, and I wasn't eating as many egg yolks as I usually do. This is probably why my homocysteine bumped. The last few homocysteines I've seen have been 7 when I'm eating enough raw.
7's very good. Homocysteine going up without liver and eggs, yes, it could, because folate could be going down. They are reasonable sources of folate.
Per day, an ounce, half an ounce a day, that keeps my homocysteine at 7 with no supplementation of L-methylfolate in my diet. Now, is homocysteine the end all and be all of the cardiovascular risk equation? No, it's not. We don't fully understand it, I don't think, but I think it is an important thing to know about. And if your homocysteine, I believe, is over 8, I would increase the amount of riboflavin in your diet. Where do you get riboflavin? Liver and heart are the sources of riboflavin.
Yeah, lamb's heart in particular is very, very good. Homocysteine is directly inflammatory to the endothelium, the lining of the arteries and veins and so on, increases the risk of cardiovascular disease, dementia, Alzheimer's, vascular dementia, stroke, certain cancers, miscarriage, preeclampsia, all sorts of conditions increase in risk with a higher homocysteine. So it is something that I think everybody should be getting checked.
So I agree with Paul that homocysteine is an incredibly important marker to look at for inflammation. In our practice, if somebody has
Yes, inflammation. Inflammation can increase homocysteine. High homocysteine doesn't necessarily equal inflammation, though.
of a 7, maybe 7.5, 8, we will generally recommend a methylfolate only because we see that there's often a MTHFR mutation.
It's probably about 50% of the population. Of those I test, anyone that has a homocysteine above about 9 or above, probably about 70 to 75% will have an MTHFR mutation. It's very, very common.
And pro tip, I don't think it's that important to test your MTHFR. I would just get your homocysteine tested.
I'd probably agree with that, to be honest. A lot of people, there's just not really that much point. Interestingly, though, I had a patient actually today who we spoke about this, and she had a high homocysteine of 17, quite high. And that's about a 3 to 4, maybe 5 times even baseline cardiac risk. So it's definitely significant. And she has other health problems that may be being impacted by this high homocysteine. She almost certainly has an MTHFR mutation, but she decided actually on balance, she would just take the methylfolate. The problem is that that really caused her actually some issues with the methylfolate. Now, that's very uncommon. I've never actually seen that before, but she's pretty adamant that the methylfolate caused her some memory problems. Now, we did a little bit of quick research in the consultation. It turns out there are certainly some anecdotes of people reporting that supplementation with methylfolate did cause them some memory and possible cognitive issues whilst they were taking it, but not permanently, thankfully. She's actually come off it and she is now going to do the MTHFR test because we want to know if she has that mutation or not, because if she doesn't, clearly something else is going on, and simply supplementing methylfolate is not going to bring her homocysteine down, because those normal folate levels are actually really good anyway.
You have a high homocysteine, it is often because there is inflammation in the body. Even if you
Again, the buzzword inflammation. With Judy, it's almost becoming a little bit of a cliche. Everything's inflammation. That's just not the case. Homocysteine can go up because you're not sleeping, you're stressed, you're insufficient in something like iron, maybe, for example, B2, B6, B9, B12, we've spoke about, zinc deficiency, selenium deficiency, all of these things, chronic stress, these can all impact on your homocysteine levels. It's not simply just down to inflammation all the time.
if it doesn't go down, it usually is indicative of inflammation. Methylfolate will reduce it, as you saw the pathway that Paul showed. But
if you have an MTHFR mutation and you are otherwise or low in folate, because you're simply just bumping up your folate levels.
Interestingly, dietary folate is only 30-ish% of that whole cycle. So whether you consume organ meats, it is usually not enough. And remember, he meant
that is quite true.
In 2022 that he was likely not eating enough organ meats, not enough egg yolks.
But where do we get folate on a carnivore diet? We basically don't, because it's not really in muscle meat at all. So if you're not eating eggs and you're not eating organs on a carnivore diet, you are most likely going to have a very low folate level. This is a problem. There can be cognitive issues, fatigue, tiredness, mood disorders, confusion, memory issues, all of these things with a low folate. And of course, you're probably going to have a high homocysteine as well, because your folate's low, even with or without the MTHFR mutation.
See what happens with 2024.
I've also recently started experimenting with methylated B vitamins. I've spoken about in the past, and I'll speak about in this podcast, the fact that I have a MTHFR polymer.
So Paul was not using methylated vitamins, and he was saying you could get everything from vitamin B2, but now he is using methylated vitamins. Interesting. Don't know why he's doing that now if his bloods were fine previously and his homocysteine was quite low previously. Yeah, interesting.
And a couple other polymorphisms within the realm of methylation, including COMT. And And then I generally feel better when I have a methylated B vitamin supplement, even if I'm eating half an ounce of liver per day. For many people, a methylated B vitamin supplement may not be necessary, especially if you don't have polymorphisms at your MTHFR gene.
I would agree with that. If you don't have an MTHFR mutation, I don't think you need methylfolate at all, as in terms of supplementation.
I thought in 2022, his homocysteine was high because he wasn't eating the egg yolks as well as his organs, and that's why it was low, but typically it's within range. But now he's saying that he's added methylfolate because it makes him feel better. But if you're getting it from organs, why do you need the excess methylfolate?
You're not getting methylfolate from organs. It's not in organs. It's still just folate. Maybe tetrafolate, not methylfolate.
Yes, the organs aren't giving you enough of the folate. Just saying.
Well, yeah, they don't. You need massive amounts of organs to get sufficient folate. But even then, with his MTHFR mutation, he's not going to be properly converting that folate anyway. So he's always really just going to need the methylfolate.
See that his folic acid
And Judy would know that. She's kind of just being a bit facetious here, I think.
is higher. And look, his homocysteine is still at 10. Okay, so
Which is suboptimal. Should be 8 or below, ideally.
to recap, Paul mentioned that his homocysteine went up because he was not eating sufficient egg yolks as well as organ meats. But he also mentions that he started taking methylfolate, and you could see that increase in his 2024 markers. But his homocysteine is still high. If Paul is consuming organ meats as well as taking folate, as well as taking the niacin that he had recommended from, again, the organ meats, why is his homocysteine high? And elevated homocysteine markers are usually because of inflammation and often points to deficiency.
No, usually it's MTHFR mutations and insufficient methylfolate in the body. Paul may be just not supplementing enough methylfolate. Just because his folate levels in the blood test are okay, doesn't mean his methylfolate levels are actually high enough. Inflammation, yeah, it's definitely a thing, but it's not the only reason that you can have a high homocysteine.
B vitamins. So if Paul is consuming enough meat as well as consuming organ meats, there should be no reason nutritionally that Paul would be high in homocysteine. Even if Paul has the MTHFR mutation, supplementing methylfolate, his folate levels are taken care of.
Yes, but are his methylfolate levels taken care of? We don't know that because, as far as I'm aware, there is no blood test for methylfolate, and the blood test that Judy's indicated just simply says folate. So we don't know if he's actually having enough methylfolate or not. Simply getting more folate in the diet is extremely unlikely to make any difference on his actual homocysteine level. It really does need to be methylfolate to actually make a significant impact to bring that level down. And maybe he's just only having it once a week. He's experimenting. Maybe he's having it every day and it's just not working and there's something else going on. Of course, that could well be the case. Again, I think Judy's just being a little bit disingenuous here and not really fully explaining this. I think because she wants to get her point across that Paul Saladino is wrong. But I think when you're giving half-truths, it just makes you look a bit silly, I think, to be honest.
Now, homocysteine increases the risk of cardiovascular disease by causing damage to the endothelial lining of the arteries, especially in the heart.
Fruit juice, not inflammatory. I've shared many times in the past multiple studies corroborating the notion that fruit juice improves endothelial function. Fruit juice is not inflammatory.
There are clear studies in humans showing that when you drink orange juice, the endothelium, the inside of your blood vessels, the lining of your blood vessels actually functions better.
It is interesting because Paul shares fruit juice supports endothelial function. So if Paul is
Which it may do.
drinking juice for support of endothelial function, I would also assume that his homocysteine would be going down.
No, those are two entirely separate things. Just because homocysteine can adversely affect the endothelial lining, the endothelium, and inflame it, cause inflammation, that doesn't mean that fruit juice having a positive benefit on endothelial function, that will somehow magically just reduce the homocysteine anyway. Again, I think Judy is being disingenuous here. I think she's kind of giving half truths. And I think she's trying to say that carbohydrates are not the fix here for Paul, but she's doing it in a disingenuous way. She's only giving half the information and she's drawing conclusions that honestly are just a bit silly.
So all we can deduce from his lab markers is that yes, he is supplementing folate, but his homocysteine is still high, which is indicative of some inflammation somewhere in the body.
Again, maybe, maybe not.
And clearly, niacin is not cutting it.
At the time of this blood work, I was traveling. I wasn't getting as much liver as I usually do, and I wasn't eating as many egg yolks as I usually do. This is probably why my homocysteine bumped. The last few homocysteines I've seen have been 7 when I'm eating enough raw liver per day, an ounce, half an ounce a day. That keeps my homocysteine at 7 with no supplementation of L-methylfolate in my diet. Iron, this is an interesting one. So iron, there's a lot of iron in organs like liver and heart and muscle meat. My serum iron is normal. My ferritin is 177, totally normal, but probably in the middle of the range for most people. I'll go back to the July 2020 labs to show you guys my ferritin was 276. Don't know why it's 54 now. The ferritin is actually lower now. If you're a male, especially, you should know what's going on with your iron levels. I don't make any medical recommendations on the podcast, but I think that a lot of us males would feel better if our ferritin levels were less than 100. And
Not sure where he's got that from, whether that's research, studies, or just his own interpretation. Less than 100, I mean, that's fine. It's fine. It's a bit low, maybe. I mean, I'd say maybe the 100 to 150 range is more optimal for people, perhaps. But I know he's even talking about below like 40 now, which is borderline iron deficiency. So I'm not quite sure where he's getting that information from about ferritin. That is something that I don't necessarily agree with Paul on.
phlebotomy has helped me get mine from as high as 332 down to now 69. It's been even lower than that at 50 or 30s in the past.
There are studies that show that if you donate blood, you can reduce your ferritin, which then reduces your risk of cardiovascular disease. In the functional wellness space, we really want to understand why it's imbalanced. Iron is what's in the blood, and then ferritin is the stored version of iron. So if we look at Paul's iron,
That's correct. Yep.
and ferritin levels over the years he's done blood work, there are imbalances that you cannot explain solely by the diet, nor does he try to explain
That is true.
it that way. And so the question is, why is that happening for Paul? You could see his iron. So
Yes, that's very true. But again, that's not necessarily because of carbohydrates or otherwise. There's obviously something else going on that Paul isn't really addressing. I think that's the point she's trying to make, albeit in a very roundabout way, with a side, of carbs are bad thrown in. What she doesn't talk about in this video at all, I haven't heard Paul talk about in this video, is copper. And I suspect Paul's having iron sequestration issues, and it's actually being sequestered and kind of held, lock and key almost in the body, not allowed to be utilized, which is why the ferritin is kind of building up in his body. The question is, why is it being sequestered? It could be these copper and ceruloplasmin levels are way out. Now, we don't have that information on here. I know I have heard Paul talk about copper before, but I don't know what his copper levels are. I'd have to pull out all his videos and so on, which I'm not going to do because I'm reviewing Judy's video. But again, I think to say, well, yes, there's obviously something going on that's not being addressed, I think is very true. To suggest it might be because his diet's not fixing it, well, yes, that's also true. To intimate that that's because carbs are bad and so on, no, that's nothing to do with it particularly here. I think really what she should be asking is, what's his copper level? Unfortunately, she doesn't ask that.
optimal ranges is 85 to 130, and it's not within range in 2020. So even when he was eating strict carnivore, he did not have enough iron in his blood. Why? When his ferritin levels, his stored form, is out of range even for conventional care.
Again, maybe iron sequestration. I've seen this a number of times on the carnivore diet. People having weirdly low iron. You'd think it'd be really high, but often that's actually low ferritin, which is a totally different thing. That's not going to be iron sequestration if it's low ferritin.
His 2022 iron levels are now higher, and actually on the other end, opposite end of being too high, and his ferritin is still out of range for the optimal ranges. Why? And in 2024 now, he shows that his iron is in one.
Okay, but unless I'm mistaken, which I may be, the 2020 results, Paul was carnivore. 2022, Paul was animal-based. So animal-based actually improved his iron levels, and the iron and the ferritin was actually a real problem when he was following a carnivore diet, as far as I can tell from these results. Again, this suggestion that, well, carnivore is going to fix everything. Well, if they were worse on the carnivore diet, surely that's not the case.
So that's now within range, and so is his ferritin, but he donated blood. Oftentimes, we will see decreased iron levels associated with iron deficiency anemia, which I don't think that's Paul, but also with hypochlorhydria, which is a sign of low stomach acid. Now,
Could be the case. I think more likely it's going to be copper. That's the problem here.
increased iron, which is 2022 when he was eating carbohydrates, it is also associated with liver dysfunction, hemochromatosis, and other infections. The
Okay, I mean, he doesn't have hemochromatosis, most likely.
ferritin, while we believe it's just that, oh, our body is storing iron, why is his iron in his blood not in ideal ranges and it's on the lower end, yet he has so much stored iron, which we actually see this in our chronic illness patients. I don't want the.
Yes, that can happen. Ferritin is an acute phase reactant. It can go up when there is inflammation. More likely, though, this is iron sequestration due to copper issues.
Community to just donate blood and not realize that there's actually an issue with their iron stores or iron levels. This is indicative of sometimes that there is inflammation. Sometimes.
Again, we come back to inflammation. Judy really does like inflammation or dislikes inflammation. She talks about it a lot. I think really the issue here with Paul's ferritin is it's most likely going to be iron sequestration, probably down to copper issues. There's all sorts of issues it could be, though. I think Judy's very correct in that he needs to look at it rather than simply saying, well, you know what, we should just do venous sections and donate blood and, you know, kind of that's almost the easy way out. That's not really solving the root cause of the problem, though. And I think Paul, again, should be looking at the root cause here. I think Judy is right in this regard.
High ferritin can be a marker of hypothyroid. Obviously, Paul's thyroid markers look good, so that's probably not the issue. But it is seen also high in CIRS or chronic inflammatory response syndrome because it can rise in response to infection or inflammation.
Which it can, but it's unlikely given that Paul's CRP, C-reactive protein, is I think 0.6, which we'll come to a little bit later in the episode. But if he had CIRS, it probably would be at least a little bit higher than that.
It can also be high because of autoimmune and liver disease. So inflammation itself can impair the body's ability to properly.
Which Paul doesn't have any obvious liver problems based on his blood test results.
Use iron. The hormone hepcidin, which regulates iron absorption and releases from stores, is upregulated during inflammation. Hepcidin reduces the release of iron from stores such as ferritin and decreases iron absorption from the gut. This can lead to iron being sequestered, where the body holds onto the iron in the stores, so in ferritin, but it doesn't make it available for use. The question is, again, why? And if it's because of inflammation or infection, why? Because I don't think this is related to eating or not eating carbohydrates.
Yeah, that's very true. But again, not eating carbohydrates, it's not related. it's most likely copper because he's not got an infection. His CRP is 0.6, and he probably doesn't have a chronic inflammatory response syndrome because, again, his CRP is 0.6, I think it is. It's likely to be at least like 1.5, 2, 3, something like that. Again, conventional ranges, not elevated, but functional ranges, yes, elevated over where ideal it would be below 1. If he had SIRS, 0.6, very unlikely to be the case.
I don't think there's any evidence that eating carbohydrates in my diet in the form of fruit and honey, primarily with milk, is in any way, shape, or form harmful for me. There's really, as I said, no evidence for harm in my blood work of any of those things, despite the fact that a lot of people in the keto or carnivore space like to claim that there would be. There's absolutely no evidence in my blood work. And I would argue that this blood work that I have looks better than the blood work that I had when I was strict carnivore. The first thing you'll see here is that my fasting.
I think I'd agree with that. To be honest, I think his blood work does look better on his latest bloods than when he was carnivore. I'd agree with that.
Glucose is 89. Remember that I eat upwards of 300 grams of carbohydrates, primarily in the form of fruit and honey every day, and my fasting glucose is still very low. Even though people in the keto and carnivore space will say that eating low carb is beneficial for glucose, their fasting glucose is often quite high. Whether or not this represents a problem for humans, we're not entirely sure. And as I've said in the past, I fully respect anyone doing a keto or carnivore diet if that's what works best for you. Triglycerides 89, HDL 53. This is where
the only thing on that previous screen, we'll come back to it, his EGFR, which is like kidney function estimation, estimated glomerular filtration rate, is only 63. It should be above 90 for his age and so on. So there's maybe something going on with his kidneys, which again is probably not, diabetic kidneys or anything. His glucose is fine. There's obviously something going on with his kidneys that, again, he's not really talking about.
these usually are in the last couple of years since I've been doing a animal-based diet.
Remember, Paul said that a good sign of insulin sensitivity is your HDL compared to your triglycerides. Now, Paul's 2024 labs show a decrease in his HDL and an increase in his triglycerides. So could that be signs of insulin resistance starting? As an
Could be. Also could be any number of things that can go on, of course.
his insulin went from 2.4 to 3.6, still in a very healthy range, especially even for optimal ranges. But if you go to his
Okay, I mean, you're literally splitting hairs at that point. 2.4 to 3.6 is splitting hairs. It really is.
his triglycerides went from 65 to 89. That is a pretty big jump. And his HDL went
Yeah, but it's not that high. It's still fine.
66 to 53.
Which has gone down, which generally is not a good thing. Absolutely.
He is now outside of the optimal ranges for HDL. How is that possible when he is consuming 2 pounds of meat a day? Unless the carbs are impacting his HDL.
No, that's not necessarily the case at all. I mean, I had a patient today whose HDL was, I'm in Australian units, 1.16, I think it was, and it's going down despite following a high, fat carnivore diet. And they could be lying to me, of course, but they absolutely swear that they are not eating carbohydrates, yet their HDL's going down. Can't just say it's just the carbs.
I surf for 2 to 3 hours every morning. I do think that all humans benefit from some carbohydrates, even if you're obese, even if you're diabetic, even if you're overweight. Getting around 100 grams of carbohydrates a day minimum will lower stress hormones, things like cortisol, catecholamines, including epinephrine and norepinephrine. And they think that their cortisol to DHEAS rate.
I don't necessarily agree with that. Yes, carbohydrates can improve things in those regards, but 100 grams is still quite high. I think minimum should be about 20 grams a day, minimum. Anything above that, that's just you to play with, of course. But 20 grams a day, yes, I would agree with that.
Would be too high because the cortisol would be high and the DHEAS would be low. You can see here my cortisol is 12.5 random in the morning, and my DHEAS, that's DHEA sulfate, was 142.
Which is low, but it has improved.
A ratio of 0.084 for my cortisol to DHEAS ratio. If you're interested in literature looking at this ratio, I'll share this study. Cortisol, DHEA, sulfate, their ratio.
The thing is there, you can't just say my ratio is great, so I'm fine, because your ratio can be very low, but if your cortisol and DHEAs are low, well, then you probably have adrenal insufficiency or adrenal fatigue syndrome, which is a big problem. If your cortisol is really high, then your DHEA is high, you also can have a problem. So yes, ratio is important, but the absolute values actually do matter as well. Again, either Paul doesn't necessarily know that, and I would question then why he doesn't know that, or he's maybe being disingenuous and not giving the whole truth perhaps as well. I don't know which.
And all cause and cause specific mortality in the Vietnam experience study. Basically, the authors say that this is one of the best ratios for longevity and predicting low rates of cause-specific mortality. I haven't heard anyone in the longevity space be willing to share theirs or talk about this ratio. So if you want to live a long time,
mine's excellent, if you want to know. I will be publishing my latest blood test soon, though I have been eating some not great diet for the last couple of weeks, but I'm going to cover all that in my blood work review episode. I'm going to get back onto my diet, exercise again, and then do it again in a month's time, but stay tuned for that.
Keep your cortisol low and your DHEAS, which is an androgen, DHEA is dehydroepiandrosterone sulfate, keep that as high as possible.
Yes, you should keep it as high as possible or within the optimal ranges. So again, Paul's DHEA is at 142 now, which is an improvement since last time.
Yeah, it's doubled. It's doubled. It's got improvement, but it's still low.
Oh, if Paul supplements DHEA, but it went from 79 to 142. 142 is obviously so much better than 79.
I think it would be unlikely he's supplementing DHEA because it really is still low. So it's probably unlikely.
It is still less than half of the ideal range for DHEA for a male. And so his body still possibly, allegedly, has low adrenal function or some level of stress.
More likely stress, given that his cortisol's generally okay. His DHEA is improved, but his cortisol's gone down. So again, it's unlikely that he's got adrenal fatigue, but it's possible. Unlikely though. More likely is some sort of chronic stress is going on here.
I put the DHEA next to cortisol, so you can see a ratio is only as good as the numbers. So yes, while the ratio of Paul's cortisol to DHEA looks good, he is very out of range for DHEA in general. So the question again becomes, why is his DHEA low? Now, one thing we test.
That is a very good question. Something that Paul is not addressed as far as I'm aware. We'll see in time whether he responds to this video, to Judy's video, probably not to mine, as to why his DHEA is low and what he's doing about it.
Chronic inflammatory response syndrome is our DHEA marker because it is often low in people suffering from SIRS. It affects the DHEA as well as it affects testosterone. Now, Paul's testosterone looks within range, so I can't really say anything there, but his...
Well, actually, no, you are saying something. You're saying that SIRS can lower testosterone and DHEAs, but his cortisol is also not very high, so it's less likely he's got SIRS without an adrenal fatigue type picture. And also his testosterone's gone up. So actually what you are saying, Judy, is his testosterone is going up. It means he's not actually very likely to have SIRS. So she's kind of, again, half truths here, saying something and kind of just, quickly glossing over it when it doesn't quite fit the narrative that she's trying to get out.
DHEA hormone may be low because his melanocyte stimulating hormone is low. Now, I would have Paul test his MSH to see if my theory is true. Again, these ratios look good, but if you're out of range, does the ratio really matter?
No, you need the
Now, Paul is right that his blood sugar hasn't gone up a lot, but it has gone up a little bit. And so we'll have to see.
Which can happen day to day.
If over time it doesn't go up, but I'll give it to him. His blood sugar is still pretty good eating 300 grams of carbs. His insulin,
his HbA1c has crept up very slightly, and that is essentially 3-month average of the blood sugar level, so 5.2 to 5.3. So yes, he is maybe getting slightly less insulin sensitive, maybe slightly more insulin resistant, possibly over time. That is very true.
going up. So we'll have to see how that continues. So while it's not a huge jump, it is going up. So we'll just have to see if this 300-gram carb diet is not impacting Paul in an adverse way.
I do think that all humans benefit from some carbohydrates, even if you're obese, even if you're diabetic, even if you're overweight.
We've heard this already numerous times.
Around 100 grams of carbohydrates a day minimum will lower stress hormones.
So Paul believes that even if you are diabetic, if you are obese, if you have metabolic syndrome, so insulin resistance, that you should still support the body and consume 100 grams of carbs at the least. That would be 4 bananas a day, or maybe 5 cups of blueberries, or 6 tablespoons of honey. If you could handle 4 bananas a day or 5 cups of blueberries and you didn't fall off the wagon, then maybe it would be okay, assuming that you wore a continuous glucose monitor and your blood sugar was still within the normal healthy range, even if you had momentary spikes of maybe 20 to 30 milligrams per deciliter.
Yeah, I mean, that's quite true. It's really the time under the curve, area under the curve for CGMs. It's not the spike that's the problem, it's how long it stays elevated for. And sometimes it's better to get a big spike and then very quickly down than it is to get a small increase that lasts for a very long time. I don't necessarily agree with 100 grams of carbohydrates for people who have gross obesity or diabetes, for example. But 100 grams, let's again give it some context. That is still considered in most circles a low carbohydrate diet, just not a ketogenic or a carnivore diet.
But most people are not able to handle it. 4 bananas.
No, I would disagree with that. 100 grams of carbs is not a lot. It's not a huge amount. Most people are probably not going to fall off the wagon eating 100 grams of carbs. You start adding in Oreo cookies and biscuits and baked goods and whatever, yeah, they're not going to handle that because those are very addictive things. Things like bananas, blueberries, they're not very addictive. I don't know if anyone's actually sat there and tried to eat 6 tablespoons of honey. Honey is quite hard to actually eat a lot of. It's actually pretty hard to eat that much. I don't think anyone's going to fall off the wagon doing that, to be honest. And that's coming from a carb addict. I eat less than this, but I don't think I'd fall off the wagon. I think I'd get pretty bloody fed up with carbs if I was eating that much honey, for example.
Becomes banana cream pie. Or maybe I don't want to eat a banana today. I am going to have banana cream pie and I'll just keep it under 100 grams. For somebody that is insulin resistant, that will make them more hungry because they cannot access the fuel, and then that will trigger a hunger response.
That may be true. The question there is, does adding carbs increase insulin resistance or just increase insulin? Well, judging by Paul's blood results, it's not really dramatically increasing insulin resistance. So, and he's eating 3 times this level. Now, yes, look, he's surfing and whatever else, but even 100 grams of carbs, again, it's low carb territory. I don't think we need to be worrying that much about it. On the subject of carb addiction, I mean, Julie doesn't really talk about it in the video. Carb addiction, and this is coming from someone who is almost certainly a carb addict. I can eat carbohydrates now and not get addicted. Now, I do have some issues still with some things like bread, for example, but I generally steer clear of those because I know they are problem areas for me. But broadly speaking, when it comes to addiction medicine, drugs, alcohol, smoking, all of these things, most people cannot go cold turkey. It just doesn't work for them. There are some things where it's unsafe to do that, like alcohol, for example, benzodiazepines, opiate addiction. It's very unpleasant, but not inherently unsafe to go cold turkey. It's very unpleasant, but not essentially dangerous. But with sugar, you're not going to get those problems. It's not dangerous, but it certainly can be unpleasant. But for most people with addictions, going cold turkey just doesn't actually work. and a planned reduction with oversight is usually a lot better. I'm just throwing that out there.
And they will want more food. Our goal when you are insulin resistant or having too much insulin is to lower the insulin so that then you're not hangry all the time. So when you recommend for somebody that is metabolically unwell to at least consume 100 grams of carbs, I'm sorry, but I think it is irresponsible.
I disagree. And this is coming from a low carb doctor, integrative GP, lifestyle physician. I do this work with patients day in, day out. I disagree. I think 100 grams is maybe 100 grams of carbs is a little bit high, but I don't think it is dangerous. I don't think it is that much of a problem. Again, based on what I've said, in terms of addiction medicine, cold turkey just doesn't usually work for most people. It just doesn't. And 100 grams is still low carb.
Especially when most people that are insulin resistant and have weight on them, trust me, I work with many of them and they
As do I, as do a lot of people.
suffer from dieting their whole life and under eating. And when they try to change their way of eating, it is so.
That is true. Yes, most of these people are chronically dieting, chronically under eating, causing themselves a lot of problems. Again, the reason why a lot of people don't want to go to zero carb, because again, it's too much of a change. Very often a gradual change will work better for them psychologically as well as potentially physically.
Hard because their body is working against them. But when they are eating a carnivore diet, their insulin for the first time is finally going down enough that they are not hangry.
That will be the same on a ketogenic diet or a low carb diet as well, not just carnivore.
Are finally having a reduction of cortisol so they could get nutrients in their system. Their immune system gets to relax because there's less inflammatory foods coming in, and they are starting to heal the body so that.
Well, yes, that's true, but you can do that with an animal-based diet. Animal-based diet has almost no toxins in as well, as far as all of those toxins that the carnivore diet is taking out. Animal-based is almost entirely the same as far as toxins from food is concerned.
The fat cells can reduce the toxins or storing of the toxins so that they can start healing.
Again, animal-based is not really any different to carnivore in that respect.
So again, if you worked with people one-on-one, you would know these dilemmas and know that it is not prudent to recommend to be eating this many carbs.
Disagree. Strongly disagree. If you're working with people purely on a carnivore diet, yes, if that's your tool, you're going to say to everyone, well, no, you shouldn't eat carbs. If you're actually working with patients who come in with a broad range of how they want to work, so someone like me who sees people from, strict carnivore all the way through to vegan, strict vegan, and I'm still trying to help those people, you've got to work with them on what they want to do and the approach that they want to take. Yes, you can guide them, of course, but you can't just say, no, you carbs are bad, you need to do what I tell you. It just doesn't work like that. They're just going to go see someone else.
You want to recommend a temporary snack, such as a keto food, so that they can heal, they can reduce their.
And most keto snacks are absolute garbage. I can't believe she's recommended keto snacks now.
Then maybe one day they can eat the banana or two. But to tell a society that is mostly overweight and half of the country is diabetic to eat carbs is probably not the most ideal thing to say.
Again, look, let's give it context. He's not talking about eating a kilogram of carbs. He's saying 100 grams. It's still low carb. Come on.
That AST and ALT are indications of liver function and or liver irritation. The other one to consider is getting a GGT. I have seen some people on ketogenic and carnivore diets see their AST and ALT go up.
I would really like to see a GGT here for Paul. It's standard in Australia to get a GGT on a liver function test. I would love to see that because that could give good indications as to chronic stress and so on, oxidative stress, don't know why he hasn't got it, because he talks about GGT. I don't know why he hasn't got it done. Very odd. His ALT is fine. His AST is very slightly suboptimal. They should all really be below 25, including GGT as well. ALP is elevated above 25. That doesn't really matter. That's absolutely fine. Let's carry on.
And I don't think that should be ignored. It does suggest the liver is working harder than it would like to be. But as you can see, my AST and ALT are totally normal.
These are liver enzymes that are indicative of possible inflammation.
So as Judy's mentioned here, she's pointing out AST is not entirely normal in terms of the functional ranges. ALT is fine, but AST is slightly out.
As you see, Paul in 2020, when he was eating mostly carnivore, if not only carnivore, his AST was still high, which normally you don't see it that high. I normally see the AST on carnivore diets in the low 20s or in the teens. So it is very odd that his marker was at 32.
I don't. I often see it being slightly elevated. Long-term carnivores, certainly their liver function can start to go up in terms of those numbers going up again long-term. So she may be seeing a totally different population than I am with carnivore patients, but I'm not seeing people in the teens as far as AST is concerned.
In 2024, it is at 30. So AST,
which is lower. Lower is better. Again, maybe a half truth here from Judy. She's not pointing out where things are actually slightly better for Paul.
can be increased with damage to the liver cells. It could be indicative of some levels of liver disease or medications or heart problems and pancreatitis. But for some reason, Paul's AST not terribly high, but you can see even compared to conventional ranges, it is pretty up there. Now, his ALT is within range.
Yes, okay, but it has actually improved. I think if Judy was doing a proper job on these results, she'd be telling you that.
If that is high, it's normally related to fatty liver, but it isn't super low. This is still within range, so not terribly worried, but I often see this lower in carnivore clients and patients.
I do not. I see it usually higher in carnivore patients. Just saying.
My kidneys work just fine. Go figure.
I don't know if Paul's kidneys are working just fine. Let's look at the
Yeah, I don't think they are either. I mentioned this earlier with the EGFR. There's something going on with his kidneys.
details of Paul's kidney markers. He shares that his EGFR is 63. So the BUN or BUN looks pretty within range. The creatinine it's actually a little bit out of range, but it's normal if you're eating a little bit of high protein. But his EGFR is 63. So this is from the National Kidney Foundation of what should be a normal GFR for people without chronic kidney disease. And so I think Paul's in the 40 to 49. So his EGFR should at least be 99 and his GFR is 63. Paul's 2022 was 82, which is still on the lower end for Paul. And this is again when he's eating carbs. And in 2024, it is 63. He can say that he was not drinking enough water, but I don't think from all of the different markers that are imbalanced, that is the only reason.
Yeah, he could be dehydrated, but his osmolality is actually on the higher end of normal, so he's probably not dehydrated. The other thing is his creatinine is a little bit high, and I don't have the numbers on the screen right now, but EGFR is a calculation based on age, sex, and creatinine levels. Let me just bring it up here. So yeah, serum creatinine, age, sex, and then that will give you your EGFR. So if your creatinine's higher, and it often will be for people who are consuming a lot of meat and or have quite a lot of muscle mass, then actually that could technically affect his EGFR, even though his kidneys are actually maybe working absolutely fine. So he probably has some issue with his kidneys, but we can't really absolutely tell from this particular set of blood tests.
Below 90 is indicative of a mild loss of kidney function. And if you go back
for normal patients, not ones on a carnivore diet or very heavy meat-based diet with a large relative amount of muscle mass, which Paul has. You've probably seen photos of him. He's pretty lean, much leaner than I am, of course. And that could be affecting this GFR, as I've already mentioned.
The National Kidney Foundation's ranges, he is well below the normal ranges. And so I would not consider Paul's kidneys, the markers, to be ideal.
Yeah, we can see from that blood test there that his creatinine is actually very slightly elevated. That could be affecting his EGFR, just saying.
Interestingly, my SHBG is 68. My last sex hormone binding globulin was 54 or 56, I believe. But
that's really high. And that's a bad thing.
You dig into SHBG, what you find is that perhaps this is not something you always check when you are fasting. This is one blood draw that I did when I was fasting.
I always check it fasted. Just saying.
To get fasting lipids, but SHBG is probably something you should check when you are not fasting. Now, why is that? Because insulin
makes very little to no difference.
Lowers sex hormone binding globulin. This is why my sex hormone binding globulin was very high when I did a ketogenic diet. It's been as high as 112 or 120.
That's enormous.
Led to free testosterone levels that were significantly lower than what I had now. Again, yet another reason that I'm not a huge fan of ketogenic diets. Your SHBG will likely skyrocket because you need some insulin to.
Maybe, but not to that level. There's something going on. I mean, like 120, 112 something is just like postmenopausal women on, with terrible chronic stress, kind of level. Something going on with his SHBG here. There's something wrong here.
Down here, blood work collected 2/26, 2024, 8:30 in the morning. That is a fasting blood draw. That's important that you understand that.
So Paul's SHBG is 68, which is out of range for even conventional ranges. And then in 2024, it's 57. So it is out of range for optimal. So Paul mentioned.
Yeah, I mean, to give you context, my SHBG is, I think it's like 14 on my latest blood test. Yeah, Paul's is way up there. Something's wrong with his SHBG.
In 2022, he learned that you should not be fasting because insulin should be activated to lower SHBG. And so when you test for SHBG, you should be eating or non-fasting. Yet Paul was fasting during 2024, and yet his SHBG went down. So low insulin can increase higher SHBG levels, but other things can too. But SHBG is produced in the liver, and liver dysfunction can influence SHBG production.
Which most likely Paul doesn't have. Okay, his AST is borderline elevated, but only really just outside the functional ranges. It's still perfectly well within the normal conventional ranges. So I think it's probably unlikely his ART is normal. We don't have a gamma GT, but it's unlikely that he's got that much going on with his liver that his SHBG is really high. Chronic stress definitely can push up SHBG. I have seen SHBG going pretty high on a strict carnivore diet, tanking free testosterone. Usually for men is usually where I'm measuring it, but also for women as well. High SHBG can cause what I refer to, it's not really a medical term, but I refer to it as quote unquote pseudo menopause. I see a lot of women coming in with what's basically menopausal symptoms, though they're nowhere near the age that they should be going through the menopause, and their hormone profiles are showing you they're not actually going through menopause or even perimenopause, yet they've got all of those symptoms. Now, often what I'm seeing there is they have this high, very high SHBG, sex hormone binding globulin. What it's doing is reducing the active free sex hormones, effectively inducing a pseudo menopause.
So if liver enzymes are only slightly elevated, this can suggest stress that is playing a role in SHBG. Iron levels on the higher side can also contribute to liver stress and
but we know Paul's are actually low now because he's donating blood or doing venesections himself. His ferritin was like, what, 57 or something, I think it was. So that's not the problem.
The SHBG levels to change. Elevated homocysteine, which Paul's homocysteine is elevated at 10 point something.
Barely elevated. That's not going to be the cause of this. That's not.
and it is a marker of inflammation. And this can also impact the liver as well as the endocrine or your hormones, your adrenals, and increase your SHBG. Look.
Again, he's not likely to have chronic inflammation. I've already mentioned that a few times.
DHEA suggests a degree of adrenal fatigue or dysfunction, which can shift the balance of sex hormones, including testosterone and estrogen, and indirectly cause SHBG to rise.
Again, yes, there's clearly something going on with his DHEAs and his sex hormone binding globulin. That's very, very clear. The question is what and why? The interesting thing, though, is his DHEAs doubled since he started, since 2022, but it was already low at that point. We don't know what it was prior to that when he was pure carnivore. His SHBG, as far as I can remember when he was pure carnivore, was even higher than this. Something's clearly going on with Paul's SHBG and DHEAs that he's either not aware of or he's not telling people. The question is what and why. I think he probably needs to address that for just his own health more than anything else.
Lower DHEA might reflect a body under stress, reducing anabolic hormones and increasing SHBG in response. So all to say, it is likely that Paul's SHBG was not just because of the carnivore diet, and it could be a lot of these other factors.
That is true. But why did it get better when he added in carbs? Why did his testosterone improve when he added in carbs? Why did his DHEAs improve? Possibly when he's added in carbs, or at least over time as well. Again, there's more to the story than Judy's kind of letting on here.
Can also cause SHBG to rise. Now, maybe on a carnivore diet, Paul was under eating fat and under eating calories.
Very unlikely.
Fasting, and that can increase your SHBG.
Yes, it can. Probably not the issue here, though.
But if he was eating an adequate amount of fat and protein on a carnivore diet, his SHBG should not be going up that much. So the question is, could Paul have a little bit of liver inflammation, which also can impact SHBG?
Well, yes, he could, but not to that degree that's going to impact it that much based on his other blood tests.
The rest of the comprehensive metabolic panel are electrolytes, quote unquote. You see sodium, potassium, chloride, calcium, etc. Most people are not going to have derangements in these electrolytes, though I have seen some people have their sodium dip when they're limiting salt.
So Paul is right.
I've never seen that. The thing is with things like sodium, potassium, magnesium, especially calcium and salt, most of these, we're measuring the intracellular. We're measuring the extracellular. So what's in the blood. What's in the blood does not correlate very well at all, often, to what's happening at the cellular level, which is where we get the issues with things like cramps in our muscles, at the neuromuscular junction, and the mitochondria within the cells in the muscle. That's not what we are testing. We're testing the blood. That's not a very good indicator of what's actually happening at the cell. And I see this all the time. People coming to me with carnivore, usually saying, I'm getting cramps, electrolyte problems, and so on. I want my bloods tested. Problem is, it's pretty useless because they're all normal, yet they're clearly having electrolyte problems, but it's just not being reflected in the blood. We'd really probably have to do a muscle biopsy at the time of having the cramp, which we don't do. It's a pretty invasive thing to do a muscle biopsy. It's not a routine thing that we just do. So blood tests for electrolytes are mostly useless.
Where your CMP ideally should rarely be imbalanced. Your body will only have it imbalanced when it's not doing so well. If you think about the blood as a highway and it's always trying to be in homeostasis, then it will always try to regulate your electrolytes to be in better balance. But that does not mean that your cells have the right electrolyte balances. That's where other tests are more beneficial to see if a 3-month cell status shows true balances of electrolytes and electrolyte function.
So even they are not necessarily very useful. Things like, red cell magnesium, red cell zinc, etc. They still don't show great correlation. They're better, but still not very good. I don't bother doing them because they really don't show much extra, to be honest. You really need a muscle biopsy, and we just don't do that routinely.
Really understand this, When we do blood work, even if you just get a typical physical or wellness check from your doctor, they will always include a CBC, which is a complete blood count. And it's basically what your blood cells are doing. It also shares immune function, infections, viral, bacterial loads, anemia, and any other blood related conditions. It is in doing the CBC that if there's anything imbalanced, that then more testing will be done to see if there's anemia or if there is cancer. Now, just a pro tip, CMPs are also tested, and that's the liver kidney function electrolyte. It does not include A1C insulin, so you will have to do that additionally. Now, in the CBC,
Not quite sure why she's really talking about CBC that much here. It's not especially useful to anything other than potentially the monocytes and eosinophils. Eosinophils are like kind of like the allergic white blood cell, though parasites as well, she's mentioned on the screen. Monocytes are more of like an inflammatory kind of white cell, and they can be slightly elevated. Now, Paul's are ever so slightly elevated above where I would like to see them. I'd like to see them 0.5, here's a 0.6. Not really a big deal, but again, there may be some sort of chronic stress inflammation going on, though things like the CRP and so on, they're all pretty normal. I think really, again, it's clear there's something going on with Paul underneath the surface. And this is kind of what Judy's trying to say, but she's kind of just getting mixed up with the agenda of, well, carbs are bad. And it'd be nice if she was just a little bit more succinct with what she's trying to say here, just saying that there's something going on with Paul that he's not addressing, rather than trying to throw the whole carbs thing in as well.
part of the immune function, we test these blood cells or white blood cells. And a lot of them is to obviously reduce inflammation and be a defense against any foreign invaders. Now, this matters because of Paul's 2022 CBC immune health markers.
As you can see here, basically all of the metrics on my complete blood count are within normal. There's nothing crazy to point out here.
Yeah, so we can see his monocytes are 0.6. I would like to see those 0.5 or less. Ideally, maybe 0.3 to or 0.2 to 0.4. Optimal probably being 0.3. Eosinophils, they are relatively low, 0.3. They should be probably less though. Ideally, maybe 0.00, 0.01. So there could be some mold issues, inflammatory stuff kind of going on, maybe some parasites and so on. It's possible. He eats a lot of raw food. Maybe Paul should get a stool test for parasites, but again, it probably would be a little bit higher if there were, parasites there.
Any current infections going on, so my white blood cell count is not elevated. My red blood cell count is within normal. My hematocrit is actually pretty darn high, something that has to do with my iron levels, probably, and just the fact that I'm an athlete. Everything else here is normal, and I won't go into tons of detail.
Now, Paul doesn't really bring.
So if hematocrit's high, that can also be dehydration, though his osmolality is actually okay. So again, he's probably not dehydrated, but there's obviously something going on with his HCT as well.
Anything other than his immune cells or immune system looks good, but let's look at his monocytes. You see also the lymphocytes as well as the neutrophils and the eosinophils. Now, he does bring up the red blood cells and how this marker is elevated. And I believe he also brings up hematocrit and that it was likely that he was dehydrated. And so some of the markers may be imbalanced. Now, remember, these markers.
Well, no, he didn't say dehydrated. He said it could be because he's an athlete, and yes, that is possible. Dehydration can raise HCT as well, but as I said, he probably isn't because his osmolality is pretty good.
And are the standard ranges. I wanted to share a study on the standard care percentage of monocytes. Now, monocytes are white blood cells that are the body's second line of defense against infection. Chronically elevated monocytes often point to a persistent infection, chronic inflammation.
Okay, but Judy's already said that you can use studies to show whatever you like. So is this that useful?
Or an immune system that's continuously activated. This might warrant further investigation, including viral, bacterial, or autoimmune conditions. In 2020, shared that his marker was 8.5. In 2022, it was 8.9. In 2024, it's actually at 10 now. If you look at this specific study, the normal white blood cell distribution is based on these percentages. So
yeah, it's going up. The question is why?
Every single human being within even the standard range, monocytes should be between 2 to 8%, eosinophils 1 to 4, basophils 0.5 to 1. So for monocytes, anything above an 8 is out of range, even for standard care. For some reason, Paul's monocytes above 8 is not flagged as out of range, but if you see, it is out of range in 2020 when he was closer to strict carnivore, and then it was out of range in 2022, which I think is indicative of why maybe carnivore didn't work enough. So
No. No, like his monocytes being elevated is not a reason why carnivore didn't work enough. Like it's two totally different things. Like there's yes, there may be something going on, but that's not they're totally different things. I mean, it just makes no sense at all to say that. You know, she's written a book called The Carnivore Cure. She's suggesting that carnivore can cure a lot of things. So if he had problems, why did the carnivore diet not cure them? Do you see what I'm saying? Like, you know, it's just disingenuous. She's kind of throwing these things out there that don't really make any sense, just with this agenda that she just wants to say that Paul is wrong. And it would be good if she just actually stuck to the facts.
markers, all of these markers are part of that CBC. His total white blood count is within range. He does mention in 2020 that he might have been sick from over exercising. So we'll give him that for why it's low. In 2022 and 2024, they are within range. Now, his RBC has always been out of range, and now it's fully out of the conventional range. So these RBCs carry oxygen to the lungs.
Yeah, I mean, he might have polycythemia, for example. I mean, Paul should get these things investigated, there's no doubt. But I don't think, again, you can say this is a problem with carbohydrates. There's something else going on with him.
And to the rest of the tissues to get basically oxygen. Increased levels are associated with dehydration, maybe stress, a need for vitamin C, probably not that because Paul eats a lot of fruit, and respiratory diseases such as asthma. Now, he could say it's because he's an athlete or that he's dehydrated, but it might also be because he's stressed or there's some type of stress
Pretty sure he's also said he is asthmatic in the past.
in his body. His hemoglobin is actually out of range, and it is close to out of range for the conventional ranges. Again, hemoglobin helps to carry oxygen. Hematocrit, he has himself said, is high. And so there would be a need for more testing for Paul to figure out what is going on. A high hematocrit with a high RBC and high hemoglobin can indicate polycythemia. It is a disease state in which the proportion of blood volume is occupied by red blood cell.
Yeah, you get too many red blood cells, basically. That could be the cause of some issues here, yes, and Paul should definitely get these things investigated. It would be unusual for the labs to not be flagging these things, though, and suggesting further investigation if they actually thought there was polycythemia. So it's less likely to be there, to be honest, but it is a possibility.
Now, it could be that he surfs and holds his breath, as he says, but I would not bet the farm on that. His MCV and RDW look within range. Now, RDW is an interesting one. You want this marker to be low. So the more that the marker is low is saying that all of your red blood cells are all the same sizes. The more that this distribution or the sizes are different is a sign that there is abnormal variations, which can be indicative of illness. So for Paul, he is out of range all the time. Now, it can be a deficiency in B12, folic acid, iron, anemia. So again,
But it's getting slightly better over time.
those questions of how come you have to supplement methylfolate, even if it's the MTHFR, why is it still imbalanced, especially with your homocysteine, your iron? Maybe you're not anemic, but why is your iron imbalanced? That you have to donate blood. Higher levels can also be a sign of inflammation or poor nutrient absorption. Remember, we had a marker that showed hypochlorhydria, which is low stomach acid. Higher percentages may indicate more variation, and it can also mean that the liver is not functioning as ideal as it should.
So there's a lot of could, may, possibly. His ranges are, you know, slightly out. They're not anything major. She's kind of making it out like he's terribly unwell and has got all these major problems going on. Again, disingenuous, I think, here.
I don't think there's any evidence that eating carbohydrates in my diet in the form of fruit and honey, primarily with milk, is in any way, shape, or form harmful for me. There's really, as I said, no evidence for harm in my blood work of any of those things, despite the fact that.
Okay, so on screen, if you're listening on the podcast, Judy has put an infographic that says 100% disagree. There is evidence many markers are imbalanced and worse. This is in reference to Paul saying that there's no evidence that carbohydrates have caused him any harm. Actually, no, I would agree. There is no evidence that carbohydrates have caused him any harm at all. In fact, all of these markers that Judy is kind of pointing out, pretty much all of them universally, I can't think of a single one, has not got better. They've all got better on his animal-based diet. The only thing that's maybe ever so slightly worse, fasting insulin's a hair's breadth higher, fasting glucose is a tiny little bit elevated, HbA1c went up from 5.2 to 5.3. Every other marker has either stayed the same or got better. These markers are not because of carbohydrate. They are down to some other problem, which is what Judy is saying in the video. But then she's just, I don't know, it just seems like she's got an agenda to say that carbs are bad. And she kind of can't separate that from the other issues. And I think that's honestly a bit of a failure on Judy's part, I got to say.
A lot of people in the keto or carnivore space like to claim that there would be. There's absolutely no evidence in my blood work. And I would argue that this blood work that I have looks better than the blood work that I had when I was strict carnivore. As you can see here, basically all of the metrics on my complete blood count are within normal. There's nothing crazy to point out here.
They aren't entirely normal, but they're pretty good, but they're not entirely normal.
I don't have any current infections going on, so my white blood cell count is not elevated. My red blood cell count is within normal. My hematocrit is actually pretty darn high. Something
that is true. Judy's put a thing on the screen saying white blood cells are not always elevated with illness. If you have chronic illness or the body can't mount a proper immune response, that is very, very true. Though I think, again, it is probably unlikely that Paul has a serious chronic, insufficiency in terms of immune system response. That's probably unlikely to be the case.
To do with my iron levels, probably, and just the fact that I'm an athlete. Everything else here is normal, and I won't go into tons of detail.
The most interesting part is his immune cells. Now, his neutrophils were very out of range in 2020, and then the monocytes were clearly out of range. But in 2022, it is still out of range, and 2024, it is still out of optimal ranges.
Which can happen for any number of reasons.
Neutrophils are the white blood cells used by the body.
But again, looking at them closely here, for the most part, they have improved over time.
To combat bacteria.
And again, they were worse when he was on the carnivore diet.
Infections. Now, remember the monocytes. But monocytes, again, are the body's second line of defense. And it could be a persistent infection, chronic inflammation, or an immune system that's constantly activated. And if you see, Paul's 2024 is worse than it ever has been. So even if Paul is feeling
marginal, but yes, worse,
great, and his testosterone's all within range, his markers are not trending in the most ideal way. Even if we were to...
One of his markers has got worse, but most of them have got better.
Compare the monocytes, eosinophils, and basophils to the standard care ranges, he is out of range even in 2024. He is at 10 when the distribution of monocytes should be at 8%. So with RDWs, you want this marker to be low. Now, Paul takes folate, so obviously then that's not the reason for this. Or can it be related to the iron, which remember Paul manipulates by giving away blood? These questions are asking, why is Paul having these imbalances? If the body has its own wisdom, why is it not balancing on its own?
Because there might be some other issues with things like copper that we've mentioned numerous times.
Why, if Paul is feeling better, is his monocytes going up? So while Paul is sharing that his blood work and his health feels much better on 300 grams of carbohydrates, there are still imbalances that have been there since 2020 or has been there since 2022, and it's still there in 2024.
Yes, that is very true. But that's not probably because of carbohydrates, which is the intimation that Judy is making. Okay, my thing frozen.
Question
Okay.
is why? Because I don't think the answer is carbohydrates or not.
Insulin is a valuable hormone. Having an after meal, postprandial spike in your insulin does so many good things for your body. It helps your body conserve minerals, it helps your body conserve electrolytes. This is why people on long-term ketogenic diets often run into recalcitrant electrolyte deficiencies, and no amount of salt or electrolyte supplementation will correct them. I've seen this over and over and over.
Yeah, I would agree. I mean, I've seen this over and over and over with carnivore patients. I've never seen it on animal-based diets, people having electrolyte problems. It just doesn't happen on animal-based. Definitely happens on carnivore all the time.
Body some insulin is a good thing. Insulin is not the enemy.
With healthy kidneys, I should be able to excrete any excess of sodium from my diet just fine. But one of the problems that I ran into on a ketogenic diet many years ago was that no matter how much salt I ate, I could not hold on to my electrolytes.
And I've had issues with this before. I found boron was incredibly helpful. I've been contacted people all over the world since that one video I mentioned boron a while ago, saying it really did help them with their cramps. Where do we get boron from? It's not the carnivore diet. There's almost no boron in meat. There's boron in organs, a little bit, very, very small amount, tiny amount in eggs, a little bit in milk. Most boron comes from fruit. It's not on the carnivore diet. And you need at least about 1 milligram a day as an adult for boron to maintain proper kind of health, hormonal health, and other benefits. You're not going to get that on a carnivore diet. It's pretty much impossible, even with grass-fed, even throwing in organs and so on. It's very, very, very difficult. This could be partially why carbs helped Paul Saladino. It's hard to know for sure. He hasn't had his boron levels checked. I don't think there really even is a blood test for boron. I'm not aware of one anyway. I do this work for patients. I've never seen one. You can get hair mineral analyses, which, yeah, they're a bit dubious of whether they're that useful or not, but you can do boron through a hair mineral analysis. I'm not aware there is a serum blood test for boron. That could be why carbs were making him feel better. Not necessarily the carbs, perhaps what was with the carbohydrates. Maybe, but you can't really get boron on a carnivore diet. It just doesn't really happen.
Let's talk about the electrolytes. So we can safely say that there are possibly some imbalances in Paul's blood work, even though they weren't flagged. Even some markers that are out of range for standard care ranges. I have no idea why they're not flagged on Paul's labs, but you can see that they are out of range. He talks about electrolytes and how protein is insulinogenic, and it is. If you eat a lot of protein, you will see your blood sugars go up.
Barely, if at all. If it's insulinogenic, that's insulin going up, not blood sugar going up. I don't know if Judy's got that wrong or it's just a mistake she's made. Honestly, I've done CGMs before. I've eaten a kilo of meat and my blood glucose has gone down, which is suggesting that it is increasing my insulin a little bit, but not dramatically. Protein does not increase insulin that much. It really doesn't. Nothing like carbohydrates will, that's for sure.
Interesting is that Paul tested his osmolality, and osmolality being low shows dehydration is not the case for Paul. Low osmolality typically indicates there's an excessive amount of fluid within the body for some reason. Now, I know this isn't flagged on Paul's because they say the range is 265 to 320, but this...
Sure, I think I maybe said his osmolality was high before. It's actually low, and yes, that means I got that slightly wrong myself. Osmolality being low does mean you're likely not dehydrated.
Actually low. And so even though Paul doesn't feel his electrolyte imbalances, Paul is still imbalanced, most likely, with his electrolytes. And by the way, we checked this mark.
I mean, maybe not. You can't tell from this. You need a muscle biopsy at the cellular level to actually really show what's actually going on. You can't really tell from these blood tests.
For SIRS because it is often imbalanced with SIRS, So low osmolality typically indicates there's an excessive amount of fluid within the body. The most common reason
She likes talking about sirs a lot, doesn't she? Everything sirs.
this result is that a person has pushed fluids for some reason over the last 72 hours. Now, high osmolality indicates dehydration. Paul's marker is low. Now, these are some of the reasons why osmolality can be low, including overhydration, antidiuretic hormone imbalances, which is something I would strongly encourage Paul to test. It could be thyroid related, which it most likely isn't based on Paul's markers, and then adrenal insufficiency, which we see that is cortisol as well as DHEA is on the lower side. So could it be
But it's probably not adrenal insufficiency.
related to that? So if Paul's osmolality is low, I recommend testing the antidiuretic hormone. And then if that marker is imbalanced, a imbalance that is beyond just having to supplement carbs or supplementing electrolytes, and it is more related to a hormonal imbalance that can be impacted by either infections, environment, other things that don't have to do with the diet.
Exactly. Nothing to do with the carbs, nothing to do with the diet. I see where she's going with this, but again, she's conflating and confusing the matter, saying that it's nothing to do with the diet. Therefore, Paul was wrong to add in carbohydrates and carbs aren't fixing his problems. But if it's nothing to do with the diet, why is he getting better with carbohydrates? The crux of it really is this is nothing to do with carbohydrates. There's basically something else going on with Paul Saladino that is not being explained. Carbohydrates may have improved some things with him, like testosterone and so on, maybe the cramps, electrolyte issues, and so forth. I've seen that numerous times, and I don't care what people like Judy say. I've seen it numerous times face to face with my patients with their blood tests. It definitely is a thing that this is a problem on the carnivore diet that carbs can fix for some people at least. But there's very clearly something else going on with Paul Saladino that he's either not aware of or he's not addressing, and it's not being fixed by the carbohydrates, lack of, or adding them in. Clearly hasn't made the difference for him.
Diuretic hormone is released by your pituitary, which also impacts your thyroid. When you are eating carbohydrates, since your body is full of water, you do not realize the restless leg syndrome or the heart palpitations because there is more fluid in the system. But that does not mean that your electrolytes are balanced.
I mean, dehydration can contribute to these things, certainly. Again, I mean, I think just kind of slightly disingenuous here. She's just conflating things and really with this agenda that carbs are bad and he shouldn't have added in carbs, which I wish she'd kind of just stick to one topic here, really.
Why people that eat a bunch of carbs still have heart attacks because they find out their magnesium is super low. In Paul's case, his osmolality.
Okay, I mean, yeah, magnesium's low for all sorts of reasons. Very commonly, things like oxalates, lectins, phytates, these anti-nutrients can interfere with these bivalent cations, Mg2+, calcium 2+, your periodic table, it's all your 2+, Zn2+, ions, Fe2+, for example. All of these things can be affected. Carbs don't magically fix everything, and so does also lack of carbs doesn't magically fix everything.
Even when consuming 300 grams of carbohydrates is low, meaning that he still has electrolyte issues. So I would strongly encourage Paul to test his ADH and see if there is a hormonal imbalance that is causing his electrolytes to be imbalanced.
Which, yeah, may be a good idea, certainly.
Not that it is because he ate too little carbs, which then reduced the insulin, which then didn't allow for his kidneys to retain water.
Okay, but why is it then that so many people on the carnivore diet have problems with electrolytes? Way more than anyone on a ketogenic diet or a low carbohydrate diet, even like, a normal standard Western diet. Why do people on the carnivore diet get so many problems with electrolytes? If it's not the carbohydrates, what is the actual problem then? She's not giving us that information.
Retain the electrolytes. In fact, ADH is the hormone that goes up when you're sleeping so that you don't wake up to go pee. And so a lot of times you'll see the ADH go down in people that have chronic inflammation and illness. So I just wonder what Paul's ADH marker is when his osmolality is low. Let me share a study on osmolality. Obviously,
I mean, ADH with sleep doesn't really have any bearing here particularly, but fine.
Paul is not on dialysis. They found that when osmolality is low, there's an inhibition of phagocyte function. And phagocytes is the
As she's mentioned, Paul's not on dialysis, so I'm not sure really exactly how this is relevant, particularly to this conversation.
of immune cell that digests harmful particles, bacteria, and dead or dying cells to protect the body. In low osmolality dialysis fluids, phagocyte function can be impaired, reducing immune responses.
Okay, but that's in dialysis fluid, not in just normal low osmolality serum, for example, which again, I'd have to look through the study, but this could be just totally unrelated and totally different. Dialysis fluid is going to be very different to normal serum.
Paul's low osmolality and his imbalanced white blood cells be indicative of some type of infection or some type of illness that is not related to carbs or not?
Yeah, probably. But that's the point, is that this is probably totally unrelated to carbohydrates. But she's saying that it kind of is, but also isn't.
I wanted to mention two other markers that I kind of just breezed through. So CO2 is the carbon dioxide. It can be low on a ketogenic diet because of ketones being more acidic. But Paul is not on a ketogenic diet. So why is Paul's markers out of range? And in fact, it is technically even almost out of range for conventional ranges. Anion gap is also similar because it is a calculation of electrolytes in the blood, and it can be higher on a ketogenic diet again because ketones are more acidic. But why is Paul's out of range when he is not ketogenic? Increased levels are often associated with the iamine deficiency, which is vitamin B1, that is the richest in pork, Paul, and in metabolic acid.
That's a dig at Paul because he doesn't like eating pork because of the polyunsaturated fatty acid. But thiamine you can get from all sorts of places. You don't need to eat pork for thiamine.
Now, actually, this should not even be yellow. It should be this orange color. So why is Paul's anion gap out of range? I don't know, because he is not on a ketogenic diet. Why is this out of range for Paul? There might be an imbalance that is deeper than consuming carbs or not.
Yeah, I mean, that's very true. Again, is this video about the problems with carbs or the problems on the carnivore diet, or that there's something else going on with Paul? Again, multiple issues being conflated here, making it just very unclear. What's clear to me is she has an agenda that she doesn't like Paul eating carbohydrates, and that challenges her way of doing things.
If Paul was my client or patient, here are some things that I would suggest. I am not giving medical advice. So stress from carnivore was likely not because of a reduction in insulin. Currently, his DHEA is still low, his SHBG is still high, and he also had a little bit of low potassium, which if he's eating a ton of fruits, I don't know why his potassium is low unless his body is not able to hold it. And not eating higher fat carnivore likely uncovered Paul's root cause deficiencies. And instead of trying to find those root cause answers, Paul felt that it was just an electrolyte imbalance, but that probably isn't the reason, and why this new diet, this 300 grams of carbs diet, is not fully fixing his blood work. I
mean, I disagree with that pretty much entirely. There's no evidence that Paul was under eating. There's no evidence that Paul was not eating enough fat. The likelihood is he probably was, given that his book, he talks about eating a ton of food and a lot of fat. It's unlikely that he was not eating enough fat. Carbs helped more than his electrolyte problems. It helped his potassium, his testosterone levels. He just felt better generally when he was eating carbohydrates. So there's more than just always electrolyte imbalances went away. Reduction of insulin, again, he's never overly really mentioned that the lack of insulin was overly the problem here. He does mention that insulin is an issue, of course. A low insulin can be a problem. But I would again disagree that this means that carbs didn't fix his problems. I mean, they clearly fixed some of his problems. They just didn't help all of his problems. And there's things which are not related to the carbohydrates, either eating them or not eating them, that Paul needs to be considering. And that's what Judy should be saying in this video.
And test his antidiuretic hormone. Could 300 grams of carbohydrates and water retention be masking an imbalance? It's also likely not dehydration, as Paul mentioned, because the BUN is higher and the albumin is not high, but the osmolality is low.
True.
The anion gap of Paul's is high, which can be common in keto, but Paul is not keto. So there is some type of metabolic imbalance somewhere and specific to minerals. Paul has low DHEA, which can mean that he is under stress or low adrenal function. His AM cortisol has dropped as well.
Again, it's probably not adrenal insufficiency, but there's clearly something going on with his DHEAs. They are very low. They should not be that low.
Yes, his cortisol to DHEA ratio is good, but his absolute numbers are not in an ideal place. So why does his DHEA look bad when Paul says he feels so great? So Paul's A1C and glucose did look better when first starting his pro-metabolic diet, or the 200 grams or 300 grams of carbs. His insulin is going up and his HDL went down, as well as his triglycerides are going up. So there are
some markers getting slightly worse. That is very true. Would be interesting to see what happens in long term with Paul, of course.
symptoms of insulin
I suspect he's just slightly overeating carbohydrates.
resistance possibly starting to trend that way. But initially, I think when he started eating carbs, his insulin was working really well and it shoveled it into his muscles as well as his liver. But now that he's been eating this way longer, could it mean that there will be imbalances over time? Who knows? Paul does surf for 3 hours, so I'm sure that is helping him a ton.
It probably is, absolutely. The question is he just slightly overeating? I mean, he's eating 300 plus grams a day. Interestingly, though, if you do the animal-based calculator for Paul and his weight and all the rest of it, he probably should be eating more like about 150. So it may just be that he's experimenting on himself and he's just trying to work out what's ultimately best for him. And I think that's perfectly fine. I don't think we can say at this point that carbs are really, small amounts of carbs like 100, 150 grams is actually causing a major problem, because he's eating a lot higher than that. So we have to kind of separate, in a way, Paul Saladino from the animal-based diet, because he is doing something actually quite different to his recommendations for other people.
Iron and ferritin levels are imbalanced, so I would test for further inflammation. I would test the inflammatory markers from the innate side, not just the adaptive side. Adaptive side is HSCRP or C-reactive protein. The innate side is the TGF-beta1, MMP9, C3 or C4a, VEGF.
Which most people are not going to be checking. You can do, of course, by all means. I would like to see an ESR, erythrocyte sedimentation rate. This kind of covers both the innate and the adaptive immune system. CRP really is more just the adaptive. So what we mean by that is the adaptive is usually like more of a response to infections and, external kind of, in a way, inflammation. ESR and the more innate, will go up when there's more just like the chronic inflammatory response syndrome, the SIRS that Judy likes to talk about, where CRP may not rise that much. Interestingly, I mean, while I don't check things like VEGF and TGF alpha and C3, C4 complement, things like that routinely, I do check ESR and I do check CRP, HSCRP very routinely for patients. And with patients with conditions like fibromyalgia, chronic fatigue syndrome, long COVID particularly, what we do see is a discrepancy between CRP and ESR. And typically, both will be elevated above where they optimally would be. Bearing in mind, Paul's CRP is pretty much optimal, so it's unlikely he probably has SIRS or anything like that, but it's possible. The ESR tends to be higher relative than the CRP. Even if it's within the quote-unquote normal ranges, it still will tend to be higher relative than the CRP, which can point you towards some sort of SIRS inflammatory response going on. And it's one of the tests that I look at for patients if I'm thinking they might have something like a long COVID, for example. It's not diagnostic of long COVID, but it can give you an idea that there may be something like that going on, because the CRP will be relatively normal, but the ESR will be relatively high relative to where the CRP is. So I'd like to see an ESR for Paul. We don't have that, unfortunately.
All markers of inflammation, and I would love for Paul to share them. Donating may actually cause further iron issues. For some people, even if they have high ferritin, it could still be that they are anemic and maybe the body is holding on to excess iron because of some reason it's trying to balance the body. I highly recommend figuring out the root cause instead of just band-aiding by donating blood. Raw milk
I'd agree with that entirely. He really should be trying to work out what's going on with him.
obviously helps to also reduce those ferritin levels. There's an article you can look up, blood donations and risk of cardiovascular heart disease in men, methylfolate for MTHFR. Folate levels look within range, but the homocysteine is still high even when Paul is taking folate. So there is likely some inflammation somewhere. Now, given the fact that Paul has
Again, there's multiple reasons why it can happen, not just inflammation. But there's clearly something going on with Paul. Either he's not supplementing enough methylfolate, or there's something else going on that's driving up that homocysteine. Absolutely.
E3 and MTHFR gene is probably not ideal to flood the body with glucose. It is an expensive, long-term, consequential band-aid. I would also have Paul consider hydrochloric acid or digestive bitters. His chloride was low, which is needed for stomach acid production. Hydrochloric acid, chloride, you sort of need those. His alkaline phosphatase is trending low, which then can be indicative that he needs more zinc. You need zinc to produce more hydrochloric acid.
If his zinc is low, that certainly could explain homocysteine being slightly elevated, DHEAs being low, and SHBG being very high. I'd like to see a zinc level checked. Absolutely. Interestingly, zinc may lead to low hydrochloric acid. Low hydrochloric acid might lead to low zinc. So it can become a cyclical problem.
Yes, there are subclinical and even not subclinical, but just not flagged markers on Paul's labs that share with me as a functional medicine practitioner that he is struggling with something. And it is not related to carbs or not. And this conversation was so important to share because it is not about the carnivore diet.
Okay, I think that's where I'm going to stop it because this video then goes into studies and so on. And I'm already like 2.5 hours. This is ridiculous. If you're still here watching me, I mean, bloody hell, thank you very much. I think that what Judy's saying is really important at the end. And this is really the takeaway for me, is there's clearly something going on with Paul Saladino that is not being addressed with his current diet. Now, of course, the basis of Paul's diet is the animal-based diet, but he is eating more carbohydrates than perhaps he's recommending other people to eat. So I do think we need to somewhat slightly separate Paul Saladino and the animal-based diet here. For me, I think what this video shows is that Paul's problems are really not necessarily that much to do with carbohydrates in the sense of there's clearly something else going on with his body, that low DHEAs, high SHBG, borderline homocysteine, the borderline issues with his blood counts, the borderline kidney issues, and so on. There's clearly something else going on that he's not addressing. What I don't think this video shows is that carbohydrates are fixing his problem or otherwise. And I don't think it shows that carbohydrates were or were not the problem with the carnivore diet. Judy, I think, is, again, I've said it a few times, but I do think this is true. I respect her and what she's doing. I really do. Anyone in this space that's trying to help people, I have great respect for. But I think, again, she is conflating the issues here. She seems to have an agenda. She seems to have an axe to grind against Paul Saladino and carbohydrates. And she's conflating, I think, the issues here. She's saying that carbohydrates were not the problem because there's other issues going on. That doesn't make any sense. You can have multiple issues at the same time. He could have whatever else is going on underneath the surface, plus also a lack of carbohydrates causing issues. It's possible to have both. I have seen it numerous times now, carnivore patients coming in, struggling, having these problems exactly like Paul Saladino said. I had these issues as well, but my SHBG was never that high. My DHEAs were never that high. My homocysteine was never that high. I didn't have problems with iron and so on like Paul Saladino does. It was the total lack of carbohydrates. When I added those in, everything got better. But I don't eat 300 grams of carbs. I eat about 20, 30, maybe 40, 50 at most grams a day. I'm still well into the ketogenic space. Pretty much whenever I take my ketones, which is very rare because I don't really see the need, I'm in ketosis. Occasionally, I will bump it up maybe once a week, once every couple of weeks to about 100, 150 grams of carbs. I personally believe that is very beneficial to not be in chronic ketosis. I think if we look at the standard human diet that we would have been eating over millennia, if not longer, hundreds of thousands, millions of years potentially, we had access to seasonal carbohydrates, fruit, honey, etc. We would have eaten it. There was no carnivore, vegan, keto, low carb. We had no idea what a calorie was, any of these things. It was all just, there was food and you ate it, and you ate till you didn't want to eat anymore. Now, most likely we were also relatively intuitive eating. Our kids eat relatively intuitively nowadays before they discover sugar and so on. And my 1-year-old does this. He'll eat a little bit of that, little bit of that, little bit of that. Even if he loves the food, he will only eat enough of it until he just doesn't want any more. He won't just keep stuffing his face with it. Now, processed food, sugar, etc., he occasionally gets that when the grandparents are in town. My mum's visiting over from the UK at the moment, feeding him a little bit of chocolate and sugar and so on. But, it's okay every once in a while. Yeah, he can't really moderate that because it's just processed food. It's designed to be addictive, to confuse the body. But proper whole food, no, he is able to moderate that. He eats very intuitively. I believe most humans naturally would have done this. We would have had access to carbohydrates seasonally. And what's that? Maybe 3 to 6 months of the year. The rest of the year, we probably would have been predominantly in a ketogenic diet, but not forever. And this very much coincides with what we see on the carnivore diet. Around that 6 to 9 month mark, people start to have issues with the lack of carbohydrates. And almost invariably, when they add that little bit of carbs back in, 20, 30, 40 grams, they tend to do a lot better. So I think Judy, she's right in the sense of there's definitely something going on with Paul that's not being addressed. I don't think she's right in the sense of carbohydrates didn't fix Paul's problems with the carnivore diet. I don't think she has shown that in this video. I don't think she can really conclude that. All we can conclude from this video is that Paul has other issues that need to be addressed. Thank you guys for watching this episode, listening. If you've stuck out, we're almost 3 hours now. Bloody hell, it's been a while. Thank you very much, guys. I'll see you in the next episode.